Yes, good morning, Your Honour.
Morning.
We are still partway through the evidence of Dr Sharma, who is in the witness box.
Yes,
Do you need
thank
Dr Sharma sworn again? Or?
I'll just indicate, Dr Sharma, good morning. Just because we're starting a new day of evidence, I need to remind you that when you began your evidence yesterday, you took an oath or an affirmation promising to tell the truth, and you understand you're still bound by that oath or affirmation? All right, thank you.
Your Honour. Dr Sharma, yesterday, just before we took a break for the day, I was drawing your attention to Annexure B to your statement, which was a flowchart titled Virtual Aged Care Services for Residential Aged Care Facilities. Do you have that document, flowchart in front of you?
Yes.
Can I firstly ask, when this was created before the pandemic or before the outbreak?
This was not created. This was not created by me.
Not created by you. Do you know who it was created by?
I don't know.
Was it a document that you were shown at the time of the Newmarch outbreak, so 11 April? Were you aware of this flowchart?
No. I don't recall seeing this document.
Just looking at that flowchart, you're familiar with it now?
Yes.
And that flowchart certainly involves your involvement directly. Dr Sharma, it's noted there in the second box, in the pathways.
The flow that I normally do would reflect acutely unwell or deteriorating patient. They would notify the GP and refer to a single point of contact. They would not refer directly to me or Dr. Fox.
So, just looking at this flowchart, do you agree with me that each of the pathways results in a phone call through to VAX, the single point of contact, namely that 387 number for triage?
Yes.
And this flowchart, in fact, was attached to your statement. Do you agree?
I don't know how I attached it there because it wasn't what I did, what we did as VAX. So I don't know who did this chart, but it must have been in my, I don't know how it got there.
But do you say that during the outbreak, likewise, you were unaware that this flowchart existed and directly involved VAX making decisions?
I'm not aware of the chart. There's another chart that we did that says the same thing.
I'll come to that. In relation, so do you have, just looking at the first box in the flowchart, acutely unwell or deteriorating resident, in terms of an assessment as to whether a resident or patient at Newmarch who was COVID positive was unwell or deteriorating, did you have in your mind an understanding as to who that assessment would be made by and what would flow from such an assessment?
Okay. So the assessment would be made by the nursing staff. And during this third, fourth week, we have locums, GPs in the facility. It could be either them or the nursing home. If the patient was deteriorating, they would make the call to us.
And in terms of the call that would then come through to you, on this flowchart, it appears to include residents who were both who met the inclusion criteria or who met the exclusion criteria. Is that correct?
Yes.
And when the phone call would come to VAX, did you have some guide or did you have some understanding that you communicated to the other members of the VAX team as to when a referral to a hospital should be made?
Yes.
And what were the criteria?
So the criteria is the exclusion criteria. If a patient is in COVID case, if they were desaturating, that is the oxygen saturation was less than 90%. If they were hypotensive, that is the blood pressure is low, or they were generally unwell.
You say that then that would escalate care to referral to a hospital?
Yes, and the other thing was most of the time we got calls that a patient had fallen while they were on anticoagulation, and that would be also they would call us, and that would be a referral to hospital.
So just so I'm clear on your evidence, do you say that if you received a phone call from Newmarch indicating that saturation levels were low, or that blood pressure was low, or that there'd been a fall in certain circumstances, they would be some of the criteria by which you would then direct that the patient be transferred to hospital?
Yes. What I would do, in some cases, we will, because we had a video conference, we'll see the patient straight away as well when they call us, see the patient, and also make the call that they should be referred to the hospital that is remotely on PACSIT.
And drawing your mind to the time period between 11 April and 24 April, namely the time period where it does not appear that there's any teleconferencing, how would you make the assessment in that time period? Or do you have a recollection of receiving calls in relation to querying escalation of care and how you met that phone call?
So over the weekend, we had calls made, but there was a call that was not made to me, but to the single point of contact when Dr. Kakat was on call. The call was made at 3:12. Dr. Kakat took the call, and I believe she met the exclusion criteria. And I'm just sorry. Can I go back? The calls were made to Dr. Kakat, also took the calls. And if it met the exclusion criteria, he would refer the patient to the hospital. In particular, in this case, this lady had a fall, was drowsy, and was on anticoagulation.
And in terms, did you have a conversation with Dr. Kakat directing him that if a resident or patient met the exclusion criteria, that they should be referred to hospital?
Yes.
And are you certain that you had that conversation with Dr. Kakat?
So when we developed our inclusion criteria, when we had our weekly meeting, we would go through the exclusion criteria, not all the time, but most of the time.
So can I just draw your attention to paragraph 67 of your statement? And at paragraph 67, you say, my recollection is that most families did not want their loved ones to be transferred to hospital, and they wanted them to remain cared for in Newmarch House. The wishes of a resident or a family member would usually be followed. In circumstances where treatment was sought that was considered to be futile, a second opinion would be sought from the ICU specialist. Do you see that statement by you there? Mm-hmm. In terms of that understanding by you, how was that incorporated into the referral to hospital if a patient met the exclusion criteria?
So it depends. We would talk to the family. So it depends on, like I said, it's case by case. So if the resident had an advanced care plan stating that they don't want to go to the hospital, but if they have a condition that met if they had a fall and they may have intracerebral bleed, we would inform the family that we'll send the patient to the hospital. Or if the patient, even if they had the advanced care plan, if they had a fall and had a fracture, we would send them to the hospital because it was something that could be treatable and it would give them pain relief and comfort.
And in that expression in the last sentence of paragraph 67, where you say, in circumstances where treatment was sought that was considered to be futile, a second opinion would be sought from the ICU specialist. Do you agree that there is no indication in the Nepean clinical records that a second opinion was sought in relation to these 19 residents from an ICU specialist?
There was only one case that was sent to the hospital, Anne Faye, but she didn't have her advanced care plan done and they wanted full treatment. So that was the only case the ICU specialist was consulted, but she went ahead and had intubation and ventilation.
But just turning your mind back to the question, in the clinical records in relation to seeking ICU advice prior to a transfer, do you agree that there's nothing in the progress notes from the Nepean Hospital that indicate that an ICU specialist's opinion was sought in relation to the appropriateness of a transfer of any of these 19 patients?
That's correct.
Object to that. That's not what the last sentence of paragraph 67 actually says, if that's what my friend's cross-examining.
In circumstances where the treatment was sought that was considered to be futile, a second opinion would be sought from the ICU specialist. Does that mean you would seek that opinion prior to transfer?
Yes.
And do you agree that there's nothing in the Nepean clinical records that indicate an ICU specialist's opinion was sought in relation to these 19 residents?
Yes.
And what do you mean by where treatment was sought that was considered to be futile? Are you referring there to a VAC's opinion or your opinion that treatment would be futile?
It was a VAC's opinion. If we assess the patient and if we were going to provide intubation and ventilation, and we thought that it would be futile. However, the family insisted on having intubation and ventilation, then we would seek an opinion. But we didn't do that in our 19 patients.
So just in terms of your thinking in relation to whether something was futile or not, were you directing your mind only to ventilation and intubation, or were you directing your mind to other factors in relation to the care and treatment of a resident?
It was general condition of the patient. It depended on the patient's comorbidities, what the patient was, taking into account the advanced care plan, that we took that into account.
And yesterday I took you to the minutes of a meeting held on the 23rd of April with the GPs by way of video conferencing. And the notes recorded that there were words attributed to you, namely that there was, consistent with VAC's view, that nothing more can be done in a hospital than what a nursing home can't do. Was that a thinking of yours? Other than intubation and ventilation, did you hold a view that nothing more could be given at a hospital as compared to Newmarch House?
So it depends on the patient's condition. So just referring to that video conference, I did attend the video conference, but I didn't correct the minutes I didn't receive the minutes of the meeting, so I didn't correct the minutes of the meeting. However, what I said was, if the patient, see, everything was, it depended on the patient's condition. They had COVID, and when the COVID happened, it was early days, we didn't have any treatment, and if they had an advanced care directive and nothing else, and family did not want to go to the hospital, the treatment that we were offering in the hospital was high flow oxygen, intubation and ventilation. And then we would keep the patient in the hospital, in the nursing home, and give supportive care.
In terms of it was early days for COVID, is it correct to say that the trajectory of COVID was still unclear? And would you agree, were you aware of the fact that on the 18th of April, Newmarch House lost 87% of their staff as a result of being being a close contact to a COVID positive resident or staff member?
Yes.
And did you have any knowledge at all, as at that date and the subsequent week, what the skill set of the surge workforce was?
I knew that the staff had COVID positive, so they went into isolation. The close contact were also isolated. And I knew that they were recruiting to staffing into Newmarch House, but I don't know the skill mix.
And did you have any understanding as to the number of registered nurses who would be caring for the patients through the dual model of hospital in the home and vax care and treatment?
I don't know.
At the time, did you have any understanding as to the ratio of registered nurse and carer to COVID positive patient at Newmarch?
I did not have any discussions.
Did you have any understanding at all as to whether or not the surge workforce, be it registered nurse or carer, had any experience in working in an acute setting or an acute hospital ward?
From what I saw in this, when the surge force was brought in, I didn't have any concerns.
And when you say from what you saw, did you attend Newmarch House personally?
Yes, I had attended on occasion to give support to my staff. But in most of the time was when I was doing video conferencing or seeing patients, or when I attended the multidisciplinary team meetings when nurses were present and looked at, I didn't have any concerns.
So from the 24th of April, you say you were able to observe the staff through the teleconferencing?
With whatever contact I had.
And when you say you attended Newmarch on occasion, are you able to say whether you attended in the first 2 weeks of the outbreak?
Yes, once.
And do you know what day that was?
No.
And did you conduct any face-to-face consultations on
Not
that
on
day?
my first visit.
Subsequent to the first 2 weeks, do you recall attending in person at all at Newmarch during the outbreak?
I went when my locum doctors were there to give them support and discuss patients, also or residents, but I can't recall the dates or when I went.
How many times do you believe it was?
I can't really remember exactly, but I think it was approximately 3-4 times.
And on those 3 or 4 occasions, did you conduct any face-to-face consultation with patients?
Just one patient who was unwell.
And in relation to coming back to the time period before the video conferencing, the 24th of April, did you have any understanding as to the regularity of observations being taken by the nurses, registered nurses, and the surge workforce of COVID positive residents?
I don't know how regular they were taking observations, but when we did our rounds, we asked them for observation, and every time we did rounds, they gave us the observation. But I don't know, I'm not clear as to how often they were doing the observation.
Did you feel at the time that the frequency or the regularity of the observations was a relevant factor in assessing whether or not a patient was deteriorating?
It was relevant. And I think from the hospital in the home notes, when they admitted the patient initially, they were saying that the patient should be isolated, have PPE precaution, and have observation twice a day.
And I'll come to that document in relation to, I'll do that now, Dr. Sharma. With respect to the twice a day, Can I ask you to go to annexure? Actually, I'll bring it up. The flow chart found at volume 26, tab 11. Are you familiar with this flow chart?
Yes,
Did you write this or co-author this flow chart?
I'm aware of this chart, and I was present. It was done as a group where there was consultation, and it was written by infectious disease consultant, and we all had consultations.
And so there were a number of you, number of specialists who created this flow
Yes.
chart, is that correct? And do you recall, was that in the midst of the outbreak at Newmarch, or was it a flow chart that was in creation prior to the outbreak at Newmarch?
It probably was in the first week, and I think there was an email sent on the 16th that we were meeting, and after the meeting, this was created.
Looking at that flow chart, firstly, this patient medically stable, the second arrow. Can I draw your attention to that where it has the first dot point as admit to hospital in the home? Is it the case that prior to this flow chart, the system in place between the model of care when VACS and hospital in the home were involved was that VACS would do the first assessment of a resident or of a person and assess whether or not they were suitable for hospital in the home care?
It wasn't happening before. This was happening only with COVID.
Well, just keep that, if that document could stay on the screen, and Dr. Sharma, could I just draw your attention to Annexure C of your statement and the second page of Annexure C, which has a model of care flow diagram. Do you have that in front of you?
Oh, yes.
And that model of care, just if you go back to the first page, as I understand it, this is attached to your statement as being what was the understanding as to the partnership between the virtual aged care service and hospital in the home for the management of patients in nursing homes. Is that correct?
That's correct.
And this was in existence from 2019?
So can I bring it to, this was in draft form, and this was developed in partnership with hospital in the home, because VACS didn't have enough workforce to give IV antibiotics. So because of that, we developed this relationship.
And that was a relationship developed in 2019?
Yes, and the consultations were happening in 2019. This paper was in draft and was waiting to be finalized, as you can see.
But was the relationship or the co-model care already up and running in a practical way leading up to the outbreak at Newmarch?
Yes.
And if you look at page 2, there's a flow chart again. And that flow chart suggests, doesn't it, that if a registered nurse suggests contact with VACS and possible hospital in the home, and the GP agrees, the registered nurse contacts VACS, and then VACS, and then VACS reviews the residents. And if VACS feels that the resident would benefit from IV antibiotics or IV fluid, then VACS refers the resident to hospital in the home as a suitable patient. Is that correct?
What happened? So what we did was, when we assessed the patient for antibiotics, and we believed that the patient needed antibiotics after doing the investigation, the VACS team started the initial antibiotics, then referred to hospital in the home for continuation. If they needed 3 days, so hospital in the home would give 2 days of IV antibiotics.
Yes, so coming back to my earlier question, my understanding from this flow chart was that the way that the shared model of care operated was that VACS would do the first assessment, deem a patient suitable for hospital in the home, and then refer the patient to hospital in the home. Is that correct?
Yes.
And looking at that flow chart, it states there, doesn't it, that once the patient was deemed suitable for hospital in the home, the GP was contacted to inform of the treatment. Is that correct?
Is it this on the screen?
On the flow chart, do you have the...
So can I just say, this was a draft copy and we weren't really following it. It was just for IV antibiotics. This was a draft. We were just using this partnership for follow-up IV antibiotics. So like you initially said, they were referred to VACS. We referred them back, we referred to hospital in the home if they needed antibiotics as follow-up. That's all we did at that time.
And at that time, did you have an understanding that once they were referred to hospital in the home, there was an onus upon the hospital in the home team to obtain consent from the family in delivering that model of care?
I don't know.
Just looking at that chart, Annexure C, page 2, from that flow chart, it suggests, doesn't it, that after they were deemed suitable for hospital in the home, contact would be made with the GP to inform of treatment, and then what was required next was that one needed to obtain consent from family. And after that, the contact with the ID consultant to make the referral to hospital in the home.
It would have been followed through.
So there was a consent process involved, is that correct, with family?
I'm really unclear about that. I suppose we always ask consent. If we were giving antibiotic, we would talk to the family and say we are giving antibiotics and what our process were. And so every time we saw a patient, they would be informed. But whether we were, because this was in draft form, whether we were following it, I'm a bit unclear.
What was your understanding at the time of the outbreak in relation to whether or not residents or their family had consented to the model of care which involved VACS and the hospital in the home delivering the care to a COVID-positive resident?
I don't think we asked the permission of the family, but when we saw the patient and we informed them, can you repeat the question again?
What was your understanding in relation to consent from the resident or the family in delivering the model of care that had been decided on?
So do you mean that the model we have put in place that we had to discuss with the family?
No, I'm asking
about the model?
Yes, I'm asking you whether you had an understanding that consent was required to discuss the model of care with the family so as to obtain consent to that model, that delivery of care.
I don't know whether I did it when that happened, but this model of care has been in place for a long time, and we have been delivering VACS into residential aged care facility for a long time. So it was only a natural process that we go in and deliver services. And when we did advanced care directives, or when we informed the patient that the patient was COVID, not all the time, most of the time, we would explain what we were doing. But generally, I didn't go asking consent with all the residents that VACS was going to look after their loved ones.
I understand. Dr. Sharma, can I draw your attention to paragraph, hold on, if you just give me a moment. Yeah, I did not. Could I draw your attention to paragraph 45 of your statement? And at paragraph 45, you outline the model of care that was being implemented and the role of VACS. and the documents which reflect the model of care that was being implemented. Do you have that paragraph in your statement?
Yes.
And Dr. Sharma, you draw our attention with respect to the model of care that was being implemented to a Nepean, at subparagraph D, to a Nepean Blue Mountains Local Health District Service provision to Newmarch House residents, which is found at volume 26, tab 20. And if I could bring that up on the screen. Are you familiar with that document, Dr. Sharma?
So this document was prepared by the Nepean Blue Mountains LHD.
But are you familiar with this document? You've attached it to you, you've made reference to it in your statement. Were you familiar, were you aware of the document?
I was aware of it, but not in detail.
Or were you aware of the contents of it at the time that you were delivering a model of care to the Newmarch residents between 11 April and 15 June?
I don't know when I saw the document, exactly before or after, but at some stage I was aware of the document. Like I said, I wasn't aware of the details. At the time, we were, when the COVID-19 occurred, there were documents, lots of documents that were floating around. And although I had made reference to it, it wasn't in detail.
So,
I object to this. If my friend probably should look at the date at the bottom of the document.
it's 1 May. So that was during the period of the outbreak.
What date was it?
The other issue is a fairly simple one, which is what the model makes clear is that it is people being admitted, if I can put it that way, in the HIT program, and that VAX is part of the resources that are then deployed. So it's not one.
Object to, I'm sorry, discursed objections during while the witness is in the box.
Sorry, is there an issue?
Yes, there is an issue. If a discursive objection of this kind is going to be taken, Dr. Sharma should be asked to leave the witness box. She's in the witness box while the document is being explained, while she's being examined on her understanding of the document.
Yes, Mr. Fordham, I don't know whether you, Dr. Sharma just gave her answer. I don't know whether you're raising a general objection about other matters or not.
Well, it's going to upset my friend. Can the doctor leave the witness box?
All right. Dr. Sharma, would you mind just waiting outside for a moment? We'll let you know when we're ready to continue with your evidence. Thank you.
It's not a criminal trial. Perhaps I'll be less discursive. The questions are put rolling up two separate concepts into one, and the doctor being asked to comment on two, a model of care that has component parts to it, and being asked about consent in the general sense. And I apologise to my learned friend for being discursive. I was trying to do it in a way that wasn't as direct as I'm now doing, with a view to saving time and not having the doctor go out. But if it's going to be an issue, I won't do it again, and I apologise.
All right, thank you.
But the objection is to the two things. I was looking at the date of the document, which falls smack in the middle of the period. And so it's not put whether it's the beginning, the end, the middle, or some other point. And then also the cross-examination is necessarily putting together two or more component parts to a model and asking the doctor to comment necessarily on what may or may not be within her component, if I can put it that way, because VAX is brought in as part of supporting HIF.
Well, Your Honour, with respect, this is a document attached to this and referred to in the statement of Dr. Sharma as being one of the documents that informed her understanding as to the model of care being delivered. I haven't as yet broken down the respective components of this document in the sense or in any way tried to do a rolled up question in relation to the document. I've got so far as drawing her attention to her own reliance on this document in her knowledge as to the delivery of the model of care.
Yes. Look, obviously, we're only just embarking upon those types of matters with Dr. Sharma. Mr. Fordham, if there's an objection raised to any other questions that Councillor Singh seeks to ask, you'll let me know.
I will. And I should just clarify one issue. What the paragraph says is reflected in a slightly different concept.
All right. I think we can continue. Could Dr. Sharma please be asked to come back to the witness box? Thank you. Dr. Sharma, sorry for that delay. We're now ready to continue. Thank you.
Dr. Sharma, do you still have volume 26, tab 20, the Nepean Blue Mountains Local Health District document in front of you?
Yes.
And I think just before you left the witness box, it was drawn to your attention that the document's dated the 1st of May. Does that accord with your recollection as to, were you a party to the creation of this document?
No.
And 1 May is somewhere about midway between, at the midpoint of the outbreak at Newmarch House. Do you accept that? 11 April is the start, 15 June is the end.
So can I just say what was happening? I was more responsible for my documents, my processes. Other things were happening. Because I was so busy at the clinical level, I wasn't involved in the, I wasn't involved in this paper, but I was aware of it. So I don't know at what stage I became aware of it, but I didn't put too much attention to this.
Thank you for that, Dr. Sharma. What I'm really trying to understand is what your understanding was in relation to the model of care being delivered by both the VAX team and the hospital in the home team. So if on that point, can I just draw your attention to the second paragraph of this document? The second paragraph of this document states that care is being provided to residents in Newmarch House through the hospital in the home services, allowing frail and elderly residents to be cared for in their home. Did you have that understanding? That care is being provided to the residents through the hospital in the home service. Did you have that understanding at the time?
It's a very difficult question because they weren't involved. So I'll just tell you how they were. Initially, in the first 2 weeks, when a patient became COVID positive, they were admitted to hospital in the home, as was happening in the community. Then they informed the patient or inform the hospital in the home, inform the patient and the family members at some time, and the care would be then be provided by the VEX team.
Yes, thank you, Doctor. That appears to be the picture that is painted on the clinical records. But can I draw your attention to the second sentence of paragraph 2, which reads, the hospital in the home team provide daily care planning for the residents, including a daily visit by an infectious disease specialist. Did that accord with your understanding as to the care being delivered to the COVID positive residents at Newmarch?
In the first week, Dr. James Brandley was seeing patients, but the group, the hospital in the home, were phoning in, but because there was communication breakdown, the VAX team was consulted. We would look into the notes. I'm just trying to paint the scenario that happened. So I'm not aware that, apart from Dr. James Brindley being there as our clinical lead, as an infectious disease physician, he was assisting us with COVID-related issues. That's all that was happening at that point of time.
And just in terms of the transfer of information in that first week, where your belief was that Dr. Branley was seeing patients, how was he communicating to you what his consultation with a patient was in circumstances where I'd firstly ask you to accept for me that in the Nepean clinical records, there does not appear to be any entry by Dr. Branley in the first week of the COVID outbreak?
There were just a couple when I looked. There was with one or two that had seen the patient and that I think he's seen the patient. I don't recall how, sometimes he rang me and spoke about the patient, and sometimes because Dr. Keket was, especially on the 17th, and there's an occasion on the 24th or 25th when he saw the patient.
He saw Dr. Branley or Dr. Keket?
Dr. Branley.
Right, so that's a week apart. Do you have any other recollection of being given a handover of information about a resident and their care by Dr. Branley?
I don't recall. I can't remember now.
So just turning to the next paragraph, the second sentence reads, the VAC service works in collaboration with the hospital in the home service, providing care planning to residents in person at Newmarch House and through telehealth consultations. Do you say that correctly reflects what was occurring if we focus our mind between 11 April and 24 April prior to telehealth?
Can't make a comment. It's not very clear to me.
If we move on, it then goes on to say that the VAX team is multidisciplinary and includes a geriatrician and nurse practitioner. That's correct, isn't it?
Correct.
You being the geriatrician and Carly Harpin being the nurse practitioner?
Yes.
And then it states that the advanced care planning support has been provided by the VAX team to residents and their families. Do you understand what is being referred to there by the advanced care planning support?
So we were reviewing the advanced care planning in COVID positive patients, as many as we could do.
And so that was a review of what was in existence?
So when we knew the patient had COVID positive, we would call the family member. The GP were also involved because they knew the patients very well. Then we would talk to the family members about the resident had COVID-19 and what were their wishes. Would they want and what were the treatment options, and whether they wanted the resident to go to the hospital or stay in the nursing home. And we would, most of the time, we would document some of these. The other things we would ask about high flow oxygen, intubation and ventilation.
And moving on to 2 paragraphs down, it then states that all clinical care provided to residents is based on their clinically assessed circumstances and needs, and with their consent or the consent of the person responsible. Is that, in terms of your own involvement, Dr. Sharma, does that accord with your own involvement? In terms of obtaining consent?
Yes.
Is consent something that one normally records in clinical records? At the usual process when obtaining consent in relation to treatment, that there is a record of it?
So majority of my residents, there were some that had the capacity to give consent about their medical care. Majority of them, if they weren't able to give consent, we will talk to the family member.
Yes, but after speaking to the family member, is that something you'd record? Is that the usual practice?
No, I don't know that I recorded everything, but I don't know whether I recorded everything. But when I had family conversation or contact, then I would document in the notes as much as I can.
And moving on to the last sentence of that paragraph, it states, this will include transfer to hospital for those when this is the most appropriate place for their care and consistent with their wishes. Did that accord with your own involvement and decision-making in relation to the COVID-positive residents? And could you just tell us, in deeming what is the most appropriate place for their care, what factors you would have relayed to a family member that fell under that, what advice you'd give as to appropriateness, as to the best place?
I can't remember the details of what I told them, but I suppose, so you want to know what I told the family member when I was sending the patient to the hospital or keeping them in the nursing home? Is that what you're referring to?
Yes, doctor.
So if I saw the patient, assess them, and I was of the opinion, and in these patients, if they were medically stable at that time, and when I spoke to the family member with regards to the advanced care directive, I would tell them that this is, should the patient be treated in the nursing home or sent to the hospital? With regards to COVID, these are the reasons which I had, like if they needed intubation, ventilation, or high flow oxygen. Otherwise, we could give most of the care as supportive care in the hospital. The thing overall was most of the patients that I was dealing with, in the older people, they had multiple comorbidities. They were on polypharmacy. Sending them to hospital wasn't the safe place to go if they could be managed in the nursing home with the care that we were able to deliver.
Why do you say it was not a safe place to go for elderly residents with a number of comorbidities?
So comorbidities, including cognitive impairment, in particularly dementia. So if we were going to send these patients from their usual environment to a hospital environment, which was not familiar, dealing with unfamiliar staffing, there was increased morbidity and mortality because, just giving an example of a patient who had dementia, they become more destabilized, they became more challenging behavior, which they became agitated, aggressive, physically and verbally aggressive, requiring more treatment than normal. We prefer this patient to be treated in their normal environment to avoid that. Now, having this challenging behavior in the hospital could result in a fall, or our patients could go there and, given the COVID situation, would lie there for a long time, risk of pressure areas. And that was the basis that we wanted patients to be treated in the nursing home if it was safe, and we could give that treatment in the nursing home to avoid them going from their normal environment, normal people who were looking after, to an unfamiliar environment.
Dr. Sharma, did you have a moment during the outbreak to reflect on the fact that these residents were not in their normal environment, in the sense that they were now locked into their room, they were now isolated to their room, and their usual care staff or nursing staff were no longer there to care for them, by way of the 87% of them having gone by 18 April?
That was in the first week, but the environment was the same. They were in their room. All residents in the Newmarch house, they had a very good environment where they had single rooms and it was en suite. If they went to the hospital, the environment would change completely. In majority of them, some of them could get single room, but in the hospitals, the ratio is very small to have single room. At that time, the patients who were COVID positive were isolated to single rooms. They would also be isolated if they went to the hospital, and they would have similar, but the environment, I think, would have been the same because we haven't moved them. Moving them, increasing their stimulus, agitates most of our patients.
Dr. Sharma, I'd like to take you to an opinion expressed by Dr. Melanie Roth, who was a chief clinical advisor, who was at the time the chief clinical advisor to the Commonwealth, to the Aged Care Quality and Safety Commission, and it's volume 20, tab 56. So, wrong tab, tab 25. Do you have that, Dr. Sharma?
Yes.
And just for your benefit, Dr. Melanie Roth is a senior staff specialist in geriatric medicine at the Royal Prince Alfred Hospital. Can I draw your attention to paragraph 24 of her statement? And if you could follow with me, Dr. Sharma, the opinion of Dr. Roth is that at paragraph 24, in hospital, the main and core focus is on clinical care. The layout, infrastructure and available expertise supports clinical care. The design of hospitals has IPC at the fore. Accordingly, it is easy to move people from one area to another just by swapping beds. The systems are in place prior to any infected patient arriving in the hospital, and each bed has oxygen, suction, space for equipment, and an emergency call system. Staff are trained for the roles they perform and are used to working in a healthcare environment. In this environment, there is immediate and ongoing access to clinical assessment, medication, intravenous access and support, medical equipment, airway and defibrillation support, and a range of specialist advice and support. These things are not easily provided in a residential aged care facility, and even where available, on an in-reach basis in a continuous and timely manner. Staff are also trained, monitored and supported to maintain effective IPC and PPE, and the bulk of the relevant workforce is clinically trained, unlike personal care workers. It is easier in this setting to transfer extra staff to support increased care needs as required. Do you agree with her the opinions she expresses there, Dr. Sharma?
I respect her opinion, but I have my opinion as well, given that I have also see the patients as well and treat my patients. So I would say, I would like, in the COVID, when we are talking about COVID, we did bring our environment in week 2, week 3, where we had doctors at the nursing home. We had oxygen that we could administer. We could give them IV antibiotics, and nurses that became familiar to the patient, and they were in their own room. Now, if they needed to come to the hospital, the VACs streamlined these admissions to the hospital. In our hospital, at that current stage, we had to streamline to where the COVID positives were, and we sort of decreased their movement if it was a planned admission, or if they get unwell at any time, we would call and make that decision. So if they really needed to come to hospital, I think they should come to the hospital. But if they could be cared for in their own usual environment, and we had the ability to provide that, then I think in patients' best interest and according to the patient's wishes, they stayed in the nursing home. And I've been looking after a lot of patients in our LHD, and majority of them wanted to stay in the nursing home if they could. And we also looked at their advanced care planning. So it is a bit of difference of opinion. In COVID, it was really hard. I would bring the patient, but it would be planned. So I think it all depended on the clinical need and what was the best care for the patient.
And do you agree with me, Dr. Sharma, that just looking at these 19 residents, it doesn't appear that a single one of them was transferred to Nepean Hospital solely on the basis of their COVID positive status and signs of deterioration?
Haven't gone, the 19 patients that were there, majority of them had advanced care directive, and as per the patients and the family wishes, they stayed in the nursing home. Those that deteriorated and we didn't have any clear plans were transferred to the hospital, and in particular one of them, Anne-Faye.
Yes, but Anne-Faye was not transferred based on her deterioration.
No, not because of COVID.
Status.
Yeah, not because of COVID deterioration, but she needed to be transferred because she had a fall.
Can I come back to what you said in your last response with respect to your opinion that the VACS team did have the ability to care for the residents in the home? Looking at the flow chart, and if Dr. Sharma could, if we could have on the screen again, volume 26, tab 11. Doctor, in relation to the capacity, the capacity of VACs and hospital and home to deliver the care as per this flow chart, can I ask you to just keep these figures in your mind? Dr. Sharma?
Yeah.
Did you want to have some time to read that flow chart?
Sorry.
No, that's okay. Just have these figures in your mind.
Which figures were
I'm
there?
going to give them to you. Okay. And then I'm going to ask you about whether, in fact, VACs and the hospital and home had the capacity, the ability to deliver the care that they intended or desired to deliver. On the 17th of April, there were 20 COVID-positive residents. On the 24th of April, there were 32 COVID-positive residents. On the 28th of April, there were 34 COVID-positive residents. By that time, namely the 28th of April, on that day alone, there were 4 residents who passed away. By the 28th of April, there were in total 12 residents who had passed away. Now, looking at this flow chart, and the context was that by the 18th of April, 87% of the Newmarch staff were no longer there, and a surge workforce had come in. In those circumstances, do you think that VACs, which had yourself having attended at that stage, perhaps on one occasion by the 28th, but not to do face-to-face consultations, you had the nurse practitioner, Hayley Carpin, who's given evidence that in total she was physically present at Newmarch on only 2 days. You had Dr. Kakat, who states that he was present at the nursing home on every day, Monday to Friday. And we have Melinda Burns indicating that her recollection is that he was there 3 days a week, and she didn't see him perform face-to-face consultations. In those circumstances, do you stand by your evidence that you had the ability to provide proper care to 34 residents, or minus 12, because 12 had passed away, by the 28th, to provide care to 20 residents who were COVID positive, who were elderly, who were frail, who had multiple comorbidities, some of which included falls, some of which included diabetes, hypertension, 2 with obstructive pulmonary disorder. In those circumstances, do you stand by your opinion you had the ability to provide care?
Object to that, and I'm not going to say a word until the witness leaves the room.
All right, very well. Dr. Sharma, I'm just going to ask whether you would mind waiting outside again for the time being, and we'll let you know when we're ready to continue with your evidence. Mr. Fordham.
Leaving aside the length of the question, if the question's going to be put, you would have to detail on every day exactly what resources were available in terms of registered nurses, enrolled nurses, assistants, general practitioners, and the like. Because it's not a simple question of all of the care being provided by VACS or HIF or anybody else. The evidence is clear on that there are, excuse me, should take this off, apologise, that there are medical and nursing staff at different times in different numbers performing different roles, performing care.
Her evidence is that she had no understanding. She had no understanding as to precisely what staff was there between 11 April and 28.
Yes.
So there's no utility. I'm asking for her opinion, whether she stands by her opinion that they had the ability. And I can add in that equation, and in circumstances where she had no understanding as to the quality or quantity of care being delivered on site by the surge workforce.
Yes, all right. Just so I'm clear in my mind, because you referred to different points in the timeline, are you asking Dr. Sharma whether she stands by her earlier evidence as at the 28th of April?
28th.
Very well, all right. Yes, I'm going to allow the question. We can have Dr. Sharma back. Thank you. Thank you, Doctor. Sorry again for that delay.
Doctor, long question. It was about the ability of FACTS to deliver, in collaboration with hospital and home, to deliver care up until the period of the 28th of April. You stand by your opinion that you had that ability, that capacity in those circumstances?
I didn't, when this was happening, I'm just saying things were happening. We were seeing the patients. Most of the patients in the initial phase, Faisal saw them on the 17th. We had discussion. These patients' trajectory where they died very quickly, within 24, 48 hours. You saw there were 3 deaths that happened in the first week. They were seen on the 17th and they died on the 18th or 19th. So they fell, that is something that we saw. But going to your question, whether we had the ability, VACS had the ability, but you remember in the first week, there was disruption. And if you put the way you put it, it's hard to say. I think the Newmarch house, we're bringing staff. I wasn't aware of the staffing in the first week. If then, and in the first week, they were seen by the doctors, but we were not on site there as much. But I believe Dr. Brenley and Kakak were seeing the patient, reviewing the patient. So your question is, did we have enough staff to cater for this patient in the first week? Is that the question?
Until the 28th.
I can't comment on that. I didn't think about it. We were just going and doing what we could do the best. Now, putting it that way, whether we had enough staffing to look after the patients. If you look at the advanced care directive, which most of them we did, the family didn't want them to go to the hospital. So we followed them. Sending to the hospital would be against the patients' and families' wishes. So it's really difficult to comment, for me to make a comment on that, whether they were adequate staffing or not. But first 2 weeks was not as good as the third week, when we had the nursing, the medical staff, the video conferencing became regular. And on the 30th, on the Wednesday, I think it's the 27th, was it Wednesday, the 27th of April, there was the locum doctor who started in the facility. We had enough staffing that could cater for the needs of all the patients.
And turning back to the flow chart, Doctor, as the lead clinician, were you aware or not whether or not the flow chart, which requires daily phone calls by the hospital and the home nurse along with VACS to check wellbeing and observations, were you aware of whether or not that could be achieved, namely that your vax nurse was able to get a report back on a daily basis in relation to 20 or more patients.
So say that again, please.
You see dot point 3 on the flow chart, volume 26, tab 11.
Yes.
The model of care was that a daily phone call by a hospital and a home nurse, along with vax, to check well-being and observations. Now, the Nepean clinical records do not disclose daily feedback on each of the COVID positive residents, daily feedback with respect to well-being and observations. Did you note that in the moment?
Yes.
And what were your reflections on the fact that the Nepean progress notes did not demonstrate that daily information on well-being and observations was being reported back?
To hospital in the home?
To you?
No, I was also, so they weren't, I was aware because Hayley Carpen was going into into eye care to look at the observations. She would report that to me as well.
Yes, but the progress notes do not reflect that is being done either on a daily basis as per the requirements of the flow chart, or that there was a comment in relation to well-being. How do you manage the care? How do you as VAX manage the care of these residents who are remotely placed without that daily information coming back?
So the nurse, so the way it had, the first week was not, there was it was total disruption and there was chaos because of the nurses, regular nurses being furloughed and isolated. The only way of communication, so it is okay in hindsight to say what you're saying. At that point of time, we were trying to look at the patient, see whether they were medically stable or not, hoping to get the nurses to make contact with us, or we looked at the notes through eye care and saw whether they were progress report that would indicate how the patient was.
Yes, and Dr. Sharma, I do have the benefit of hours and hours to spend on reflecting. And my question to you ultimately is, did you at any moment in time, either alone or along with Dr. Branley, have an opportunity to reflect and retrospectively see for the last week or the last 2 weeks whether this intended model of care could in fact operate so as to provide the best care to the residents at Newmarch? Did you have that moment? Did you have a discussion with Dr. Branley to that effect?
I don't recall, but we did not reflect. We discussed patients. And it's hard for me to remember what I did exactly then, but please note that the patient's care was foremost in our minds. Majority of the patients, it's very difficult to answer what you're asking. We did talk about the patient, whether we reflected, I'm not really sure. We discussed patients and we see what we could do to make it better. We were trying to get things in place to come, because we saw that there were no physiotherapists, they needed podiatrists. We were reflecting. But to point to the first 2 weeks, I don't really recall exactly what we did.
And in those first 2 weeks, I think you said in the first week you've used the word chaos or disruptive. Whilst there was still disruption and chaos, did you think that perhaps as a first line of treatment here, until the disruption and chaos could be managed, that it was best to transfer the COVID positive residents to hospital?
I didn't think about that. I don't know whether we discussed that. When we were dealing with this on the first week, looking through most of the patient's notes, going through observation by Dr. Keket that was transmitted to us, patients were medically stable. They weren't desaturating. The blood pressure that we recorded, not on a daily basis, but what was recorded was within normal range. I myself didn't think about it. So I don't know who makes the decision to send them to the hospital because of the initial chaos. I don't know.
Is it fair to say, Dr. Sharma, that the mindset of Nepean Hospital was not to spread the virus into the community? Was that an expressed desire?
I don't know. That was the general desire. I mean, at that time when COVID came, it was a pandemic, it was early days, and we all didn't want it to spread, but I don't know whether it was Nepean Blue Mountains, LHD's desire. I don't recall talking to them.
Was it the case, Dr. Sharma, that the model of care being adopted in relation to the Newmarch outbreak was to prioritise reducing the risk of infection into the community over and above delivering individual care to the residents?
To me, my first priority was delivering the best care to the patients in residential aged care facility as a geriatrician. And also at the same time decreasing the risk. But the first thing was looking at patient care.
And in looking at patient care, can I just now go to a different area, namely palliative care? Dr. Sharma?
Yes.
Drawing your attention to palliative care, the clinical records for Nepean tell us that when a teleconferencing on the 24th of April commenced, it appeared to commence in conjunction with a palliative care specialist.
Yes.
Is that your memory?
Yes.
And in relation to the prescribing of crisis medications, yesterday you gave evidence that you did consult with a palliative care specialist before that was implemented. Is that correct? And that was to get advice, was it in relation to dose and frequency of administering morphine and midazolam?
Yes, that was to see what protocol they had that we could go and write for anticipatory medications in the residential aged care facility.
And how much experience, if any, did you have with the palliative care or the end of life stage of patients you treated in the past?
Quite a lot.
And is it fair to say that in relation to that end of life phase, that in the non-COVID era, family members could often be with their loved one for as many days or hours as they wanted to be in a hospital setting? And would it be fair to say that one of the benefits of having a family member there with somebody in the end of life phase is that that family member is a good observer as to whether or not the patient is agitated, is suffering, has pain, is struggling with their breath? Is that correct?
Yes.
And I take it the relevance of PRN medication or medication as required is that if somebody's observing the patient, they can see whether or not they need more medication, whether or not they need no medication, as in the end-of-life medication. Is that fair to say?
Yes.
And do you agree that that's a difficult task to support a person through the end-of-life phase if there is no one there to either continuously observe them or to observe them on a very regular basis?
So most of the cases in COVID, there were no family members around, given the public health requirements. in most of the time, if we are writing the PRN, it is the nursing staff who would pick up the signs of deterioration. And yes, I would agree if the relatives were there, but relatives do not continuously monitor the signs. They would indicate to us if they are distressed. But I expected in this case the nurses to have in their scope of practice to recognize the deteriorating in the end of, if they were distressed, if they were agitated, or they were in pain, that they could give the medications based.
Dr. Sharma, your evidence is that you didn't have any understanding as to the number of staff per resident available, and therefore you didn't have any understanding as to the capacity that any nursing staff had to observe and the frequency of that.
But nurses are nurses. They have that in their scope of practice. You can't take that away. There was a palliative care nurse, Monica, who came and gave evidence. From what I saw, the nurses had expertise to look at the patient and able to assess when. That is what we do. Even in hospital, it'll be the nurses who would first alert us that this patient is distressed, in pain, or is very short of breath, and when they could give the medications.
Yes, I understand that, Dr. Sharma, but you had no understanding with respect to the frequency with which a nurse had the capacity to see any one of their residents who were in the end of life stage.
But my understanding is nurses were there in the nursing home prior to COVID. There was only one nurse per ratio, but during COVID, there were more nurses that I saw, registered RN, than we had when there was no COVID. I believe, I can't tell you the ratio per nurses, but I really believe there was nursing staff who could assess.
Dr. Sharma, are you aware that on one day, namely the 20th of April, there was a single registered nurse who turned up at Newmarch, and there were no other nursing support staff there until calls were made? Are you aware of that?
No, I wasn't.
I believe that's the evidence of registered nurse Emma Cardwell.
So the thing is, I wasn't there.
Wait,
No, I have an objection. And I'll do it in the absence of the witness for.
All right, very well. Dr. Sharma, I'm just going to ask you again, sorry, if you wouldn't mind just waiting outside, and we'll continue as soon as possible. Thank you. Ms. Richardson.
In my submission, given that there seems to be more detail to be followed up in relation to this question, it should be clearly put to this witness as to the time period in which there was only one RN. My recollection of the evidence of Ms. Cardwell was that calls were made and other RNs were found. In my submission, the inference of the question at the moment is, in effect, there was a day where there were no RNs, and the tail of the question saying until calls were made does not clarify that the problem was, in effect, fixed, and it's not being put to her on an accurate basis of the evidence in my submission.
I did say, and then calls were made.
Yes.
Until others, and we don't have, from registered nurse Cardwell's evidence, she couldn't give us a timeline as to what period of time it took before others arrived, only that they did.
Yes.
So with respect, I don't believe I've inaccurately put the evidence at all. It was the 20th of April, she arrived alone, and then calls were made and staff turned up.
Yes, I agree. I think Dr. Sharma was going to answer was in the middle of answering the question anyway, but I allowed that question. We can have Dr. Sharma back. Thank you. Thank you, Doctor. Yes, Ms. Maswa.
Dr. Sharma, the question I asked you was whether or not you were aware that there was an occasion where, on the 20th of April, where a nurse arrived, she was the only nurse present, calls were made, and then other staff arrived.
I don't know.
Would you agree? Are you aware of a comfort care plan? Have you seen something similar in the PN hospital?
Comfort care plan?
Yeah, if you're comfortable, in removing your mask. Sorry, it just makes it easier for me. Are you aware of a comfort care plan that's implemented in a person's during the end of life phase?
It is the anticipatory medications and the oral care, pressure area care.
Yes. And what's your understanding as to what the usual frequency of attending to something such as a comfort care plan is?
It's required. Regular pressure area care is 4-hourly turns. But it's really hard for me to comment on my impression of the nursing care that was delivered. I believe they delivered the best care. I didn't look into what care they were delivering with regards to comfort care to the patients.
But just on that point, if you were part of the care team, and in fact as the geriatrician, one of the leads in the care team, why is it that you didn't look into precisely what comfort care was being delivered to these residents to see whether or not the nursing home remained the appropriate place for care?
I object to that.
Yes.
I think I can do this. That question is the first question that has in it an inherent criticism of the doctor in circumstances where she's actually not on a notice.
I see. Ms. Martwa?
Your Honour, these questions have all been, and I've made it expressly so in some of the questions, with respect to the capacity of the team, of the VAX team, to deliver the care.
Sorry, Doctor, just wait for a moment, please.
A question which asks, why didn't she... Dr. Sharma's given evidence that she didn't look into that. In my submission, given it's an inquiry and we're examining the system here, the model of care implemented, it's not intended as a criticism, it's intended to understand how this care model continued to exist when there were gaps in the knowledge, including gaps in the knowledge by Dr. Sharma as one of the lead clinicians.
Yes, look, I agree. I think probably, Mr. Ford, I was going to say, I probably understood your objection to be the framing of the question in relation to whether Dr. Sharma undertook to do something or not do something in particular. But sorry, you were going to say something.
No, I wasn't. I was standing up out of respect. You were talking. That was all.
Oh, I see. No, sorry, I'm just responding to what Ms. Martline said. Thank you. Yes, I was saying that, look, I apprehend the objection to be in relation to the framing of that question. Look, Ms. Martline, I'm content for it to be explored, but perhaps that question framed or explored in a different way.
Yes, Your Honour.
I'm sorry. The only reason I stood up is I thought you were addressing me.
No, not at all. Thank you.
Dr. Sharma, could you just assist us? What was your reason for not looking into precisely what the delivery of that end-of-life care was?
So, as you know, we were the specialist geriatric service delivering the care, medical care, into the nursing home. Our expectations was we would say what the care was, and the care would be carried out by the nursing, like pressure area care. The comfort care would be carried out by the nursing staff. At no time did I have any concerns that it wasn't being carried out, I'm not responsible for the basic nursing care that is provided from the VAX team. I'm the, from the VAX team. We were not looking, my expectation was the care would be delivered by the nursing staff and they would be there to provide the care. So I didn't, it's a long time ago, but I wasn't concerned that that care wasn't delivered to the best of my memory.
Doctor, I'd like to take you to one last piece of the evidence, and it's expert evidence from Professor Curl. It's found in volume 29. Tab 2. Doctor, do you have Professor Curl's report in front of you?
Yes.
Can I ask, have you seen this report or read this report?
No.
Could I draw your attention to paragraph 165 of Professor Curl's report? And could I ask you to read to yourself, Dr. Sharma, paragraph 165? Dr. Sharma, have you had an opportunity to read that? Firstly, I'd ask you to assume that Professor Curl has had the benefit of reading the clinical records both from Newmarch and Nepean Hospital in relation to each of the 19 residents. Am I right in assuming that some of the matters that she raises in her opinion, namely that in one instance there was an oxygen cylinder which was empty, was not something known to you?
No.
Am I right in assuming that in relation to instances described where there was no medication available for residents, this was also not known to you?
Oh, no. But can I just point to you, the section number 165, or paragraph, this is in reference to hospital in the home model. She hasn't said VAX.
No, but Doctor, in terms of, sorry, I'm being corrected here, in relation to the last dot point on the page where 165 is, she does make mention to the fact that although there was geriatric medicine expertise available through VAX as a virtual service, this did not appear to influence management of residents in the same way as what it would if they had been admitted to an acute aged care ward, where a comprehensive geriatric assessment would have occurred and that there would be involvement of a multidisciplinary team with regular review by medical staff and access to other specialist advice. So it does appear that her opinion incorporates the involvement of VAX.
So that is her opinion. At the time that COVID was happening, this, apart from having high flow oxygen and intubation and ventilation, the management plan, yes, was similar. Yes, they would have access to PACE calls and MET calls, which people would be accessing immediately. And nurse, but see, the doctors still, the nurses would have the expertise that would apply, but I can't comment on her opinion. And yes, I may not be aware of the gases weren't available. I thought things were happening. If it wasn't, it was replaced very quickly. If the medication, I know on a couple of occasions when crisis medications were not there, we had it delivered through Nepean Hospital. So I don't know. I can't make comments on her expert opinion.
I'm just asking you in relation to her opinion. Her opinion is at 165 that in her opinion, the model was unable, the hospital in the home model, which we now know also incorporates the VAX, was unable to provide a hospital level of care for the Newmarch House residents who were COVID positive. Do you agree or disagree with that opinion?
I can't comment. I can't comment. She's made a number of things. And just reading through it quickly, I think she's referring to more hospital in the home. She mentions VAX at times. But see, in a geriatrician's point of view, the hospital in the home is a model, which is hospital in the home, that delivers service relevant to their scope of practice. VAX is a geriatric outreach service. I don't think that's been highlighted here. But I can't comment really what she's saying, because they say that most of the patients that we saw in the initial and subsequently, they were obviously stable, medically they were stable. Those that deteriorated had advanced care directive or plan in place by the second, third week. In the first week, yes, a patient died very quickly. Things happened very quickly. And that was the trajectory of the disease of COVID-19. So taking that and putting it here, I would say I can't comment on her statements.
Is it your opinion that VAX, in conjunction with the role played by hospital in the home, was able to provide hospital level care to the 19 residents who passed away at Newmarch?
They weren't hospital-like, I would agree, but not hospital-like hospital, same as hospital. It was, almost similar to hospital in the second and third week of the COVID outbreak.
And in relation to, can I ask you, if there was a patient who wished to remain, no, I'll withdraw that. They're my only questions. Thank you, Dr. Sharma.
I'm sorry, it's hard.
No, I understand it was a difficult time for all of you at Newmarch, and thank you for your time.
Dr. Sharma, I'm just going to check with the other lawyers. Dr. Sharma, I'm just going to check with the other lawyers whether they have any questions for you.
Yes.
Ms. Clark, do you have any questions for Dr. Sharma?
No, no questions, Your Honour.
Thank you. Mr. Palfrey, any questions?
No questions, Your Honour.
Thank you. Ms. Furness, do you have any questions for Dr. Sharma?
Nothing, thank you, Your Honour.
Ms. Richardson, any questions for Dr. Sharma?
No, Your Honour.
And Mr. Ford, any questions?
No, thank you.
All right, thank you. Well, Dr. Sharma, there are no more questions for you. So that means we're finished with your evidence. Thank you very much for attending across 2 days, and you are now excused and you're welcome to leave the witness box. Thank you. All right, just knowing the time, we'll take a break for morning tea now. I'll come back at 12:15. Because we are breaking a little bit later, I propose to take the lunch break at 1:15, unless that causes anyone any difficulties. All right, very well. Thank you. I'll adjourn temporarily. Harris.
Thank you, Your Honour. Next witness will be Kathy Dempsey. Kathy Dempsey, please.
Silence, please. Do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth and nothing but the truth? If so, please say, I do.
I do.
Thank you, ma'am. Please have a seat.
Thank you. What's your full name, please?
My full name is Kathleen Margaret Dempsey.
Thank you.
I prefer Kathy.
Sorry, say that again?
I prefer Kathy.
Kathy, you prefer Kathy. I'm grateful, thank you. You're a registered nurse, is that correct?
That's correct.
And you're also, relevantly, the Senior Manager, Healthcare Associated Infections at the Clinical Excellence Commission, is that correct?
So that position title has since changed and is now the New South Wales Chief Infection Control Practitioner and HAI Advisor.
Thank you. HAI being Healthcare Associated Infections, is that right?
That's correct.
Thank you. Among other things, you are an infection prevention and control practitioner, is that correct? If you could help us with a description of what that means. What is an infection prevention and control practitioner?
So I'm a credentialed expert, ICP, so my responsibility is really setting up policies, procedures, supporting staff normally at an LHD to prevent infections, so healthcare acquired infections. Also helping public health to make sure that anything sort of within the hospital remains, so that it doesn't become a public health issue. So there are a number of key elements of appropriate infection prevention and control programs that include things like implementing hand hygiene, personal protective equipment, education and training, surveillance on healthcare acquired infections, prevention of those, management of communicable diseases to prevent spread within hospitals and other community settings, but mainly associated with healthcare.
Thank you. And is your role, I take it, a statewide role? Would that be correct?
So currently, yes, I'm employed at the Clinical Excellence Commission, which is the lead agency for quality and safety improvement for New South Wales Health. And the IPAC, or Infection Prevention and Control, and the HAI program sits within quality and safety at the CDC, which is a statewide role.
Very well. And have I understood your previous answer correctly? Part of your role is sort of policy-based in terms of devising policy or guidance, is that correct?
That's correct.
And part of your role is also more, can I say this, practical, in that you're providing advice to LHDs or other organisations on infection prevention and control. Is that correct?
The role is primarily strategic and primarily, policy-driven. However, given the nature of the profession, there's a practical element, and throughout COVID, there's definitely been more, I guess, of a practical. Plus, I like to be practical. I feel like writing policies, you really still need to be connected clinically.
And on occasion, does that practical element relevantly include reviewing the practices in a particular workplace or healthcare setting?
Yeah, quite often. Workplaces, businesses, sporting teams, anything that has that infection control lens.
Relevantly for our purposes, you had involvement in particular in Newmarch House on and from the 1st of May 2020, is that correct? And in essence, you performed a review as part of a team, I think, and provided reports, is that correct?
So I took a team, I guess, seeing what it was unfolding in the media. I felt important to take more than just myself, so that we could get a good understanding and appreciation and the ability to provide some sensible advice.
Thank you. And I'm going to bring you to some reports that you prepared in relation to that aspect of your role in a little moment. Before I get there, just in terms of your earlier answer, you said you're a credentialed infection prevention and control practitioner. There's an organisation, I presume, which provides that credentialing. Which one is it?
So that's the Australasian College for Infection Prevention and Control.
And are there a number of people with equivalent qualifications to yourself? Do you know how many there are currently?
So there's currently about 79 credentialed ICPs across Australia. 39 of those are credentialed as experts. and that's a peer-reviewed credentialing process, which is quite rigorous. That's not to say that there's not a number of other people that may meet the requirements, but for various professional and personal reasons have not taken up credentialing.
And you hold the expert element of that credential, is that correct?
I hold, yeah, a CICPE, which is the expert level.
Thank you. One thing that I should confirm, you previously gave evidence in relation to this aspect of your working life in the Royal Commission into Aged Care, Quality and Safety.
That's correct.
And accept me, there's a transcript of your evidence within the brief. But one of the matters you were asked about then, and I'll go to it now, is the fact that you refer to principles of infection prevention and control. In particular, there are a set of 7 principles of COVID-19 infection prevention and control, to which you refer in your reports. If you just explain at a broad level what they relate to, what are they?
So the principles of infection control really don't change that much, regardless of the setting, and they're usually things like, application of hand hygiene, the appropriate application of PPE, physical distancing itself pre-COVID wasn't an element on its own, but it's around appropriate placement of patients, appropriate movement, environmental cleaning and disinfection. It'll be the appropriate isolation, implementation of precautions, and also the cleaning and reprocessing of reusable medical devices are the main sort of key themes.
Very well. And relevantly, just to put this in context, there's a document within the brief. I may not need to take you to this. It's Your Honour's volume 26, tab 5, but it's a document entitled Infection Prevention and Control, COVID-19 SARS CoV-2 Residential and Aged Care Facilities. It's a 12th of March 2020 document, and it's produced in part by the Clinical Excellence Commission. I can see it's being obtained for you now. We might actually have, if we're able to do this, we might put the first page up on the screen. Volume 26, tab 5, please. Do you recognise that document?
Yep.
Have I understood this correctly, that this is part of the source for identifying those principles of infection and prevention and control that are relevant to COVID-19?
That's correct.
So I think it's on second page of this document where they start. You can see under the heading, the first heading on the page, this was a document which was published in March 2020. And was it against these principles that you later came to assess the position in Newmarch House in particular?
Yeah, you would normally use this as your basis in the absence of a template for review. So you would apply these principles and base your review on those.
Very well. And in your earlier answer, you'd mentioned the fact that physical distancing wasn't sort of per se part of the principles prior to COVID. Do I take it that these principles are generally drawn from pre-existing principles in relation to prevention and control of infections?
Yeah, so most of what we pulled out of COVID, we basically pulled out from existing documents, rebadged them and just added the COVID. So they've been around from, probably around about the 80s, but there is definitely a national infection control guideline that these, and particularly aged care, base their infection control on. So we would pull from those in our statewide policy directives.
The thing that was added, is this right, is the physical distancing, which was a particular feature of COVID infection.
I mean, physical distancing, we would have termed, isolation, segregating, separating, minimising, introducing other personnel into the environment. So the term physical distancing probably wasn't really used to the full extent until COVID.
Very well. So most of the principles which form the principles of infection prevention control for COVID were pre-existing, that is, they were relevant to other types of infections even prior to COVID, correct?
Yes, definitely, yes.
In any event, those which were advised in relation to COVID were certainly available in this document as at March 2020. Is that the case?
That's correct.
Okay. You also said in an earlier answer that the principles of infection prevention and control would be applied across all healthcare settings. Is that right?
That's correct.
Are there nonetheless some differences or challenges implementing practices to prevent infection within an aged care setting?
There's a few different challenges because the environment's different. So healthcare is almost a sterile environment. We're built specifically with that in mind. Aged care is normally more targeted at, a homely environment, promoting a communal type living, which some of those elements are almost in competition with infection prevention and control, but you can still apply principles. It's just with modification.
So do I take it that the hospital is particularly well set up for infection control because of its physical environment? Is that the case?
Yes, it's reasonably, yes.
Well,
yeah.
In contrast, perhaps in fairness, in contrast to an aged care setting which may not be as well set up for infection control.
Well, I would argue that they need to be well set up because they are dealing with an element of healthcare. So the requirements are the same. They just need to adapt and adopt based on their environment.
Very well. A couple of other withdraw the word difficulties, a couple of other differences that you identified in your previous evidence between imposing infection prevention and control measures previously and the situation under COVID were these. Firstly, you referred to the enormity of the task. You might recall giving that evidence. What were you referring to? What was the difference that COVID brought about that created an enormous challenge from an infection prevention and control perspective?
Well, I think, where do we start? There were a lot of issues around COVID, and particularly some of the enormity was the political pressures, the media pressures that we usually don't have to deal with. And so some of the responses were based on some of those decisions outside of infection control. And, I think the sheer volume at that point, the fact that there were multiple agencies on site that, again, would be fairly unprecedented in outbreaks.
Very well. Another aspect that you identified as a difference was the anxiety, in particular of staff around COVID. I've just asked you to expand on that. Was it your impression that there was, and I want you to fix your mind if you can, on the period April to June 2020, was anxiety among staff about the risk of COVID something which you observed?
So there was a lot of anxiety with all our clinical health staff, whether they were in aged care or acute care, and that was evident by, I think a lot of the questions that would come to us, a lot of the, criticism sometimes with the guidelines, a lot of the critiquing. So I think it's fair to say that there was a lot of anxiety generally in the public, and healthcare being at the forefront, regardless of whether it was acute care, mental health, disability or aged care, or had, similar experiences, I think, with anxiety.
And does that anxiety play into the way people approach things like infection prevention and control? Does it affect what people do in terms of their use of PPE or their approach to patient care, in your view?
I think it's less the anxiety and more whether or not they've had adequate education and training and experience that should play into it.
Very well. I'm going to move to a different topic, which is the outbreak that occurred at Dorothy Henderson Lodge. Now, you were to some extent involved in the response to that outbreak. I'd just like to start with how that came about. How did you first become involved in the outbreak at Dorothy Henderson?
So I basically had a phone call at 8 o'clock at night by the Chief Health Officer asking if I would attend, that there had been another case identified. Another of my colleagues from Northern Sydney LHD, who was a ICP, had spent the previous day, night into the early mornings and was not available. And so I went on that night.
ICP, is that infection control practitioner?
That's correct.
And that colleague was not available, and therefore did you commence the following day?
I turned up probably, I got the phone call about 8 and arrived probably around about sort of 9ish.
Oh, I see. So the same day you got the call?
Yeah.
And did you, just perhaps if you can, unpack your first impression of what was going on at Dorothy Henderson. And I ask these questions only because I'm going to come to ask about a comparison with Newmarch House, if you can do that. What was your first impression of the scene at Dorothy Henderson Lodge and from an infection prevention control perspective?
I guess there were a lot of people. I mean, it was 9 o'clock at night, so there were definitely sort of no residents around, although there was one resident who liked to wander a bit, and they were sort of near the front door. And there was a very large presence of Dorothy Henderson staff, ops managers. It was very clear there was a structured sort of entrance in. I was greeted at the door. They sort of took me through. It was busy with a lot of PPE and a lot of, I guess, activity, but it seemed to be organised.
In terms of your role during that outbreak, did you remain or return to the site over the subsequent days?
Yes.
And what was the nature of your role? What were you doing while you were on site?
So really at that point, it's really just providing consultation. So I don't have any specific governance, role, but it's around how I can provide information on how they can perhaps improve their infection control, reallocate isolation, look at the quality and degree of PPE. The first night, for example, they had some alcohol-based hand rub, but not a lot. So I was able to navigate that from the state. So kind of those things, and just really providing with consultation on how they can improve their approach.
At the time you were there, was there anybody else providing advice from an infection prevention and control perspective?
So you have senior nurses who, by their very scope of practice, are required to have certain skills in infection prevention and control. So the basic things around hand hygiene, PPE, things like that. So they were definitely able to provide that consultation, but there was not essentially a lead for infection control, nor was there an ICP on site.
And is this right? You effectively took that role. You became the lead from the perspective of infection prevention and control.
Yeah, until they set up, like a conduit, so that we had a link to provide someone with some information.
To give us some context, the call you got from the Chief Medical Officer, I think, was on the 4th of March. Which would have been about day 2 of the outbreak at Dorothy Henderson Lodge. Does that accord with your recollection?
Yeah, that's correct.
And you mentioned in that earlier answer that while you didn't have any specific clinical governance role, you nonetheless provided advice and guidance to staff. Is that correct? Was it well received? Was there any pushback against the advice you were giving that you can recall?
No, that they were very welcoming, and anything that we sort of had to say, they were very accommodating. There was a very big presence of structure and executive presence at Dorothy Henderson.
That is the executive of the organisation that ran? That's
right, of the organisation that ran.
Okay. And in terms of your role in that particular outbreak, you've described your experience and your current role. Even back then, I think you were in the role described as the Senior Manager, Healthcare Associated Infections. Is that correct?
That's correct.
And a level of seniority and expertise on this particular subject, you'd agree?
That's correct.
You might recall this during the course of the evidence given before the Royal Commission. There was a reference to a concept that you were, in effect, the one voice of truth. I don't know if you recall that phrase being used, but the concept, as I understand it, is that given your background and your position in terms of expertise on infection control, people deferred to your opinion. Is that consistent with your recollection?
I'd like to think it's me personally, but I think it's actually the Clinical Excellence Commission. We actually purposefully spent a lot of time promoting that the CEC was the one source of truth, and in that group we have a governance structure that has a couple of ICPs. We have an infectious diseases physician, and then we have senior ICPs from across the state.
Do you perceive that to be an advantage in that the advice that the CEC is giving is likely to be accepted by those receiving it?
It's probably a double-edged sword. It's definitely from the CEC, but I think some of that also comes down to personality. So at Dorothy Henderson, for example, my colleague from Northern Sydney, we job shared for 16 years, so she's very formidable, and so most of that she set up very quickly. It's very hard for a lot of our clinicians to say no, because we've got a lot of years of experience and used to having pushback, so we're not shy in pushing back.
Understood. If you're able to comment on these matters, please do, and if you're not, please say so. But I'm just trying to draw out some of the differences between the way things progressed at Dorothy Henderson Lodge in comparison to Newmarch. One matter that arises from the evidence, and this is in particular from a statement of Melanie Dix, D-I-C-K-S, who's with Baptist Care, certainly was at that time, that's Your Honour's volume 25, tab 1, who notes that at the commencement of the outbreak at Dorothy Henderson Lodge, the staff were all deemed to be close contacts and as a result were furloughed or removed from the site. Was that your understanding?
That was my understanding, yes.
And as a consequence of that, there was an agency workforce which was recruited in its place. Was that your understanding?
That's correct.
And were there any issues that attended that fact, the fact that there was an agency workforce on site when you arrived?
No, there wasn't any issue because it was really the Dorothy Henderson, execs such as Melanie and the other staff really still took the lead in terms of, setting out structures, schedules, anything on PPE training stuff. So there was a clear hierarchy within Dorothy Henderson.
And when you say hierarchy, do you refer to the clinical governance of the staff
that's
working under those?
Yeah.
Dr. James Brownlee, an infectious diseases specialist, also attended at Dorothy Henderson Lodge. Was that your understanding?
Yes.
And you saw him there and did you work with him on site?
Yeah, so we ran a forum for other staff on site.
On a forum on what?
So because there are other homes on the site for Dorothy Henderson, we basically held a town hall forum for some of the other staff that were still managing on site. So there was another home associated that had some other respiratory infections. So it was really just a Q&A to assist with some of their anxiety.
Understood, thank you. One other matter, I don't know if you recall this. Do you recall what the process was with those residents who became infected with COVID at Dorothy Henderson Lodge, and whether they were transferred out to hospital?
I wasn't really involved. I know some patients were transferred, but I'm not aware that all of them were transferred.
Very well. I just want to go to Newmarch House and pick up on some of the points you've just given in your evidence in relation to Dorothy Henderson Lodge. Your involvement at Newmarch House commenced on about 1st of May 2020, is that correct?
So that was when I attended on site.
Okay. Well, tell us, how did that come about? Did you receive at any stage a similar call to the one you received in relation to Dorothy Henderson Lodge?
So it was a similar call sort of a couple of days before that, I think it was one of the public health directors that had been meeting with Newmarch and had said that they really need some help. I'd had a phone call from Melanie, who was also on site, to say it would be helpful, but I couldn't really go until I had public health approval to go.
And Melanie, you're referring to Melanie Dix from Baptist Care, is that correct? Who by that stage was, to your knowledge, in fact on site at Newmarch House?
That's correct.
Just thinking that, so there was a phone call or some contact with you a couple of days prior to the 1st of May. Had there been, to your knowledge, any suggestion prior to that point that either you or somebody else from the Clinical Excellence Commission should attend to advise or assist at Newmarch House?
No.
Did you become aware as to whether or not there were any infection control practitioners involved in the site prior to your own attendance?
Yeah, so we were aware that the Nepean Blue Mountains CNC3 for infection control was involved and on site.
One particular person who's identified in the material is Robinson.
Yep, that Robert was the CNC for infection control at Nepean Blue Mountains at the time.
And to your knowledge, was he involved in attending at Newmarch House to provide input in relation to infection control prior to the 1st of May?
He was involved on site.
I want you to fix your mind, if you can, on the day you first attended at Newmarch House, and what was your impression of the organisation of the site at that point in time?
Well, it was very secure when we turned up. And there was some media out on the sort of main street going into the site. Once we parked, and then we sort of went through to the front door, there were a lot of staff and a lot of different agencies and a lot of PPE being worn right through the facility.
Well, and as a result of what you observed and what you found out that day, you prepared a report, is that right?
So given we were asked to go and look and review, and there was some urgency to that, we almost dictated as we went round. So I had someone sitting back at the CC, preparing based on our notes, and then I finalised that later that night before sending it up, yes.
Very well, so that's the 1st of May. I might just have that displayed on the screen. So it's Coroners Volume 21, tab 22.
Thank you.
This is a copy of that report, is that right?
That's correct.
So I might just take you to, it's a document which will speak for itself, but I might just take you to a couple of bits to identify them. Just have a look at page 2, please. After you provide a summary of the background and referred to that first site visit, you've got a heading entitled Compliance with 7 Principles of COVID-19 Infection Prevention and Control. They were the principles I asked about earlier, is that right?
That's correct.
Is the format of this report that you've essentially assessed the processes or environment of Newmarch House against those principles?
Yeah, in the absence, as I said, with no template for these kind of reviews, then we did assess it based on those so that we had a framework to work with.
And in terms of your findings, one of the findings that you identified was the level of PPE that was being used within the facility. What was your impression as to PPE use on that first day?
There was a lot of PPE being used, and possibly there was a lot of confusion between using it at the clinical bedside and then moving through to other areas of the home.
And in terms of the emphasis you put on a lot being used, does that mean excessive quantities, or does it mean something different?
Well, it really just meant that now just about everyone we saw was in what was being termed as full PPE, which included gowns, gloves, some hair protection, respirators, shields, goggles, overboots, by staff that were either both clinically or not clinically involved.
And was that not necessary or appropriate in your view?
So normally we'd have a staged approach with PPE and we'd allocate different zones based on risk and based on, I guess, activity. We would try and set up zones where we would often call them sort of grey zones. So they're areas that staff can go where there shouldn't be any crossover and contamination, so they wouldn't be wearing as much PPE. Very well.
Tell me if this is right. Did you, against those principles, assess the situation at Newmarch House, and you made recommendations in this report and indeed in subsequent reports? Is that the process that you undertook?
Yeah.
And to pick up on another aspect of this first report, on page 3, so over the page from where we're looking at the moment, under the heading Application of Standard Precautions for All Patients, But one of the things you've noted, and if you see on the page, it's under the heading review, about point 3 of the page.
Yeah.
You've said difficult to assess level of understanding of all staff and level of competence for all infection control requirements. Just ask you to expand on that. What was the difficulty?
So because there are a lot of agencies on site and not really knowing, once everybody's in full PPE, it's very difficult to see what classification of staff are what. It was difficult to really understand how they were applying the zones on that first impression. It was difficult to understand who had clinical responsibility and who had, you know, who had like non-clinical responsibility. It was just a very challenging environment when you first go in there. It was quite, well, it was just busy, to be honest. There was a lot of people.
I might pick up that point. If we just turn to page 8 in the same document, this is under the summary that you provide, because you make a number of comments on this theme. One is, if you see in the second line, are you able to read that text on the page? It may be a bit small, but...
No, I can see it.
Yeah, okay, so it says there is a visible presence of facility and operational management, however, a lack of infection prevention and control expertise. Mm-hmm. You later go on in the second paragraph to say this: what was evident from entrance is that the many staff members and different agencies on site, which creates a level of chaos and crowding, the overall governance to pull each of those agencies under one reporting structure appeared lacking. Clinical management stroke leadership models would also facilitate a consistent and controlled clinical environment. Was it your impression that the consequence of the number of agencies, the number of different agencies that were then in operation was causing a problem as to who the leader was?
Yes, so although there was some Newmarch House management on site, there wasn't a clear hierarchy that the clinicians on the floor seemed to know or understand. So a constant theme was the clinicians on the floor didn't seem to know who they needed to go to if they had questions or concerns.
And was there a particular recommendation you made in relation to that going forward?
So normally that would be outside infection control, but as a registered nurse, when you go in and see these things and see that there's a, you know, normally within nursing there's a definite hierarchy. You know, you've got, in aged care you might have AINs or ward assistants, and then you've got the, you know, EN, and then a registered nurse, and then you might have a team leader and things like that seem to be missing, which would be normal practice of an aged care facility outside of COVID. That seemed to be missing.
If you can, are you able to contrast that with the position that you observed at Dorothy Henderson Lodge? Was it the same? Because you also mentioned at Dorothy Henderson Lodge agency staff being present.
Yeah, it was a completely different environment. What I took away from Dorothy Henderson was that they had clear management structure from on site. You know, regardless of what agencies came in, they clearly continued to manage the site. They had clear direction on scheduling and making sure that staff were aware what their escalation process was. I didn't get that same sense at Newmarch House.
In terms of the clear executive presence you observed at Dorothy Henderson Lodge, you're referring to executives within the organisation, so within Baptist Care?
That's correct.
And did you observe the presence of the executive at that facility?
At Dorothy Henderson? Yes, I did.
And was it the same situation at Newmarch House or not?
No. We didn't see that level mostly. It took quite a while before we really understood what the structure and who was who. And even some of the clinicians that were left on site from Newmarch often struggled with who their reporting lines were as well.
Another matter you picked up in this first report was the zoning of residents, that is the movement of residents at that point in time. as at the 1st of May when you first arrived, what was your understanding as to what was happening with COVID negative or positive patients within the home?
So my understanding was that they'd already put a lot of effort into creating COVID positive zones and COVID negative zones. Newmarch House, by their very design, is actually an area that's designed quite nicely for containment. You've got defined separate areas that you can close off with doors. And so they'd sort of implemented that. They'd implemented COVID negative, COVID positives within those areas as well, and had started to apply some of the containment methodology to confine those zones within their own zones.
Very well. And was that the start of that process, was that something you contributed to or advised about?
So I probably had a phone call with Melanie Dix soon after she arrived, and said that she was implementing some of the principles that we'd applied. Dorothy Henderson sent me a couple of photos to just let us know that's how they were going. And then on site, when we were there that day, it was very evident by, the plans that they had drawn up, and they had, pictures of the layout with colour-coded of where all the positives were versus negatives.
Very well. So that was something already entrained by the time that you arrived?
That's correct.
Okay. Now, one thing you also note in your summary, and this is a summary that I take from your evidence you prepared or dictated on the evening of the day you actually first attended on the 1st of May, you say this, it's again page 8 of that report, you say, this summary is not, it's the final paragraph of this page, this summary is not a reflection on the staff or management on site. Their dedication and commitment to providing care to the residents in such difficult time is outstanding. It does, however, provide an opportunity to review an approach when providing increased staff and external staff. The overall governance, including at a clinical level, needs careful consideration, planning and execution. And you go on to mention the fact that the presence of an infection control practitioner cannot be underestimated in those circumstances. Just the commencement of that quote, you held the view, did you, that the staff you saw performing their roles were had dedication and commitment to their role, given the difficult time they were providing it?
So every staff that we came across, and we would walk through the centre and to get a sense of, how they were coping, what their challenges were, how they were implementing things, how they were donning and doffing. Every staff member was there to try and make sure that there was adequate care for the residents, and there was a general care. Not one staff was there sort of going, I don't want to be here. They were busy, they were challenged, but definitely were there to try and make a difference.
As at 1st of May, which around 20 days into the outbreak, you were still able to observe a number of matters where you felt recommendations could be made for change. Is that right?
That's correct.
And you devised an action plan setting out what needed to be done. Is that correct?
That's correct.
I think on my count, you or members of your team then attended on 11 occasions over the subsequent month or so, and you provided a report on the 24th of March and again in early June. Is that correct?
That's correct.
What
I do need to say is normal process, even in an acute care facility with infection control. It's a constant reminder of reviewing things and a constant, I guess, improvement methodology where you'll go through a ward and go, well, I've noticed, ABC, can you make sure your staff do this? Maybe we need some education. So to imply that is different in aged care to acute care is in fact incorrect. That's the nature of infection control.
Is it common in your experience to find individual staff members need reminding of particular processes that they need to undertake? Is that part of the experience?
All the time, most definitely.
We've had some evidence from a witness in these proceedings in relation to the process of donning and doffing a PPE, which she expressed as being second nature, given she'd worked in an acute setting. Mm-hmm. Was it your observation that perhaps some staff are less used to actually using donning and doffing PPE?
Well, actually, Newmarch set up a really good process so that any person that was coming on site before they were inducted onto the units, they had to go through basically a real-time education training on donning and doffing, and they were signed off on that spot. So the actual donning and doffing itself isn't an issue. It becomes how you apply that, how you make changes during your visit with, cases or non-cases, how you might transfer that between cases, how you may not remove PPE appropriately when you're moving out of a clinical zone. It's more the operational, but to the donning and doffing specifically, they had an amazing setup really on making sure that anyone that came through could actually don and doff. The educator did try and go through occasionally through the units to make sure that people were in the right PPE. But again, there was like one person that was doing that.
I asked you earlier about the position at Dorothy Henderson Lodge, and in particular about the advice or guidance that you gave during that outbreak and how it had been received by the staff within the site. You gave a number of recommendations here, a lot of which we find in each of your reports. How was your advice received within Newmarch House?
For Newmarch House, it just didn't seem as seamless. So, sometimes there was a little bit of pushback. Sometimes we would make recommendations and then overnight something would happen. There would be either another case or, some event would happen and either Newmarch would change the recommendations again, or one of the other agencies might have. It took us a little while to really pin down that seamless approach and make sure that there was a hierarchy.
Does that issue you've just identified with making recommendations and then them apparently being changed, or the practice being changed, does that inform your view that there needs to be very clear clinical leadership lines in a situation such as an outbreak that occurred in Newmarch House?
Yes.
And in terms of the other aspect that I took you to just a moment ago, your recommendation is to the need for an infection prevention and control expert, or somebody you describe as a champion being in the role. Is that for similar reasons?
Yeah, otherwise what tends to happen is we've all seen, infection control play out in the general community, and everybody seems to be an expert on their opinions with infection control. And when you roll off the elements, they're fairly simple. You would think, well, hand hygiene's pretty simple, those sorts of things. But to actually drill down to the experience of infection control, to be able to critically interrogate the clinical area and then apply risk mitigation strategy requires an element of experience. But these are aged care facilities that infection control is required to be part of, your program. So it's not like it's foreign or it's new just because you're an aged care facility.
You ultimately make a recommendation for there to be an infection prevention control practitioner on site at Newmarch House, correct?
Yeah.
And to your knowledge, during the course of your involvement in Newmarch House, did somebody step forward to occupy that role?
So initially, it was one of the senior leads from Aspen who actually took up that lead and would check in with either myself or one of the senior colleagues that I took out there, with any questions and things like that. But we'd implemented a daily infection control plan that they could sort of run off and sort of set them up. But yes, they allocated a senior person.
Very well. And in terms of that issue you identified on the my word pushback against your recommendations, was that something that was resolved during the period of your involvement in the outbreak?
Yes, it didn't take very long to resolve.
Why do you say that?
Well, I guess when I'm asked to go to an area like that, to provide expert opinion and guidance, I didn't have jurisdiction. So normally aged care under the arrangements for, Commonwealth versus state, I wouldn't normally have jurisdiction. So quite simply, if they didn't want to take my advice, I was more than happy to bow out. And that's basically what I advised, that, if I was there for a reason, if they didn't want to take that advice, then I was happy to go back to doing 16, 17-hour days for other urgent issues. And so, yes, it was resolved very quickly.
I might move to your final report, which we find, I might just ask for it to be brought up on the screen again, within volume 20, at tab 114. I think the date is the 11th of June, but this is a report. It says at the end is in fact authored by Carolyn Ellis, I think a project officer then within the CEC, is that right? Yeah. Although under your direction and support, correct?
That's correct.
I just want to pick up, because this was at the end of the sort of the arc of your involvement in Newmarch House. If we have a look through to page 2, please, there's a table just setting out the response to the recommendations you'd made on each of the 7 principles of COVID infection prevention and control. I mean, is the sum of it that there were, as at 24th of May, efforts still being made to address some aspects, in particular physical distancing, but by the time of your review on the 3rd of June, everything had been implemented or was being continued to be implemented?
Yeah, pretty much. But, again, by the nature of infection control, it's kind of like the infinity sign. You kind of start and you keep going, and there's always constant reminders and ongoing input.
On the occasion of your later visits, you identified a particular issue with the waste management, which you've dealt with in the body of your report. I don't need to turn it up, it's page 7. I just want to take you to your overall impressions, which is at page 6, please. And you set out here a number of matters forming the impressions of your team as at early June 2020. One of them was that the house was visibly clean with nil rubbish observed on the floors. And you go on later in the report to talk about the lack of clutter. Was that something you'd observed at the commencement of your outset, of your involvement at Newmarch?
So in the early days, there was still, it was a homely environment. There was a lot of sort of clutter around, a lot of what we would term collateral, so inanimate objects and things like that. So a lot of PPE was kind of everywhere rather than being, I guess, strategically placed, and that had definitely improved over time.
So you were able to observe the improvement in the home during the period of your involvement?
Yes.
Can I just take you to the final comment you make, which is on page 8. You make a couple of points. Firstly, under the heading summary, it was evident during this visit there has been a commitment to ongoing training and education to establish a solid foundation for principles for infection prevention and control. The reference there, a solid foundation, does that pick up on the comment you've made previously in your evidence that it's an ongoing process?
That's correct. Yeah.
It needs constant review, I take it.
That's correct.
And does that inform the reason why you recommended there be an expert on site in a home such as Newmarch House?
Well, yes. I mean, we would recommend anyone that is delivering any sort of care has someone who is responsible in leading to make sure that there's compliance with infection prevention and control. That even includes your, the day procedure areas.
Yes. Thank you, Ms. Dempsey. Those are the questions from me.
Ms. Dempsey, I'm just going to check whether there are any further questions for you. Ms. Clark, do you have any questions for Ms. Dempsey?
No questions, Your Honour.
Thank you. Mr. Palfrey, any questions?
No questions, Your Honour.
Thank you. Ms. Furness, do you have any questions?
No, thank you, Your Honour.
Ms. Richardson, any questions?
No, Your Honour.
And Mr. Fordham, any questions?
No, thank you.
Very well. Well, Ms. Dempsey, that means we've come to the end of your evidence. Thank you very much for attending today. You may leave your seat there. You're excused. Thank you.
Thank you.
Is that a convenient time now, Your Honour?
It is. We'll take a break for lunch and come back at 2:10.
Silence, please. All stand. Coroners Court.
Harris.
Thank you, Your Honour. I call Christine Giles.
Thank you.
Silence, please. Do you swear by Almighty God that the evidence you shall give will be the truth, the whole truth and nothing but the truth? If so, please say I do.
I do.
Thank you, ma'am. Please have a seat.
Thank you. If you feel comfortable to do so, would you like to remove your mask? Thank you. Could you commence by telling us your full name, please?
Christine Winifred Giles.
Thank you. Ms. Giles, you, I think, are a registered nurse by training, is that correct? You have been a registered nurse, in fact, since 1980, is that correct?
That's correct.
And relevantly for our matters, is it correct you commenced working in the field of aged care from about the year 2000?
That would be correct.
I think there was a period following about 2006 you moved into a different role before you then commenced with Anglicare in 2015, is that correct? You were initially a care manager and then residential manager within the Donald Coburn Centre, is that correct? And subsequently, you undertook a role relevant at Newmarch House, who I'll come to ask about in a moment. But can I ask you, are you currently employed by Anglicare or not? Okay, and when did you leave their employment? Do you recall?
The end of April.
Is that this year?
Yes.
Thank you. In terms of your involvement in Newmarch House COVID outbreak, you prepared a statement in April and May 2021. I'm just going to ask for that to be shown to you now. It's our volume 23, tab 5, please.
Yes.
Thank you. It's also displayed on screen, but can you confirm that's a copy of a statement you prepared in April but finalised, I think, on the 10th of May 2021?
Yes, that's correct.
It's about 22 pages long and there are a number of annexures to it, but have you had a chance to review that statement recently? Yes. Are you happy that the contents are true? Yes. Thank you. Look, I won't be going through everything in your statement. Do you now have some recollection of your involvement in Newmarch House and the events that occurred there?
Yes.
I'm going to commence, if I can, with the manner in which you became involved in the outbreak. You've told us in your statement, this is paragraph 15, that you, in fact, did not volunteer for the surge workforce. Is that correct? You had, I take it you're aware that a surge workforce was being recruited by your employer during about March into April 2020, is that correct? You didn't put your hand up for that, as it were. So how was it you came to be involved in Newmarch House?
I was approached by my manager, Eric Aldiger. He came to my home and advised that that they needed some more support at Newmarch. That the manager of the home was struggling at that time, and that they needed more clinical support, and would I be able to go there?
Thank you. We can take the statement off the screen, thank you. And in terms of following that contact from Mr. Aldiger, withdraw that. At that point in time, do you recall what your role was within Anglicare?
I was the manager of the Donald Coburn Centre at that time.
Okay. Your response to his request?
I agreed to go. I felt that that I'd had experience with managing outbreaks in the past, and that there was also the fact that I didn't have any young children that were needing me at that stage. Well, I didn't have young children, so they were grown up, and I felt that I was probably in a position that I could assist.
Very well. Just pick you up on a couple of points there. I take it the latter point, you didn't feel there was a risk you'd be exposing your family to COVID. Is that the effect of it?
That's correct.
We've heard one other witness, I'm referring to other people, moved out of their own homes and stayed at motels during this outbreak. Were you in that sort of situation? Okay. Did you stay in a motel throughout the time that your involvement in it?
I stayed off-site for a period of up to 4 months. I think it was up to about 4 months, 3.5 months.
But by which do you mean you stayed in motel or temporary accommodation throughout that period?
Yes, I did.
Were you able to return home at all during that time?
In the initial stages, I was very concerned that
Sorry, Ms. Giles, I can see the evidence is affecting you. Just take a moment.
Yeah.
I think there's a drink of water in the witness box.
I think there was a risk that I may have got COVID. I think all of us were worried about that. And I didn't want to expose my elderly parents as well, or my family. Sorry.
That's quite all right. Just take a moment.
So I decided to stay off-site. And I went home on occasions, but I would self-isolate. Yeah. Sorry.
That's quite all right. Do we understand, Ms. Giles, from your reaction that you found that a very personally challenging time to be involved in this outbreak?
I've been nursing for 45 years. I've never experienced anything like it. And I never want to do it again.
You referred in your earlier answer to the fact that you had been involved in previous outbreaks. I'm just going to ask you about that.
Yes.
Your role at the Donald Coburn Centre was as the manager.
That's correct.
Do we understand that is that the residential manager or?
That's correct. Yes, I was a residential manager. I was a very clinical manager, though. I've got a lot of clinical experience, so I was a very hands-on clinical manager in the home as well.
Very well.
Yeah.
And if you can bring to mind an outbreak that occurred within the Donald Coburn Centre, just by way of example, what sort of outbreaks are we talking about?
Influenza, RSV, gastroenteritis. I think we had an outbreak in December, Christmas time, just before me going out, and again in January. So I'd had outbreaks. They were contained very quickly. And I had a lot of experience working with public health unit, particularly at Hornsby Hospital.
Prior to your involvement in Newmarch, did you think that experience was going to assist you in being able to respond?
I did. I felt that if we managed it like we generally do, a respiratory outbreak, then we could contain it. I knew they had single rooms. I knew that the home was I asked a few questions. The home was fairly well, I thought, could be contained fairly easily. I felt.
And you're saying I felt and I thought. Do I take it your expectation you found out was wrong?
My expectation was wrong.
And did it, in the event, did the experience you'd had in previous outbreaks prepare you for the sort of outbreak you were dealing with at Newmarch House?
No, it didn't. I guess in managing infection control, as far as managing donning, doffing, hand washing, that sort of thing, yes. But there was a lot of publicity about COVID and a lot of deaths overseas and a lot of concerns about running out of PPE. I've heard it over and over on the radio, on news, and I guess all of that had an impact. So
I'm going to come to ask you about some specifics in a moment, but one of the things you just mentioned in that answer was your concern about COVID running out of PPE and the impact that that might have. Did you get a sense that there was that sort of concern or anxiety generally being felt by the staff involved in Newmarch?
Yes, I believe that they were concerned that we wouldn't have sufficient PPE because it was constantly on the radio about doctors in the States making their own PPE and you know, in Europe, and we were hearing that all the time. And to be honest, when I was preparing my home for the outbreak, I was in a fortunate position. I stocked everything because of the outbreaks that we'd had. So I'd ordered in a lot of stock, but I know that when we were trying to then, when Baptist happened, we tried to increase our stock, and we were told that the Commonwealth was stockpiling, and so we had limited access to PPE to stock up the homes, and so it all had to go through our Sheehan, who was managing stock. So I was worried that we would run out of PPE, definitely.
Understood. And do you recall people being generally, that is staff being generally concerned about the possibility that they themselves might become infected?
Absolutely.
But do you think it played out at all or affected their ability to provide care in any way?
No, I don't think so. I think everybody did what they had to do. I don't think that impacted. They wouldn't have. There were some staff that refused to go, definitely. There were people that turned up, didn't know that there was COVID in the home, hadn't been told by the agency, and left. So definitely that happened. But the staff that were in the home, the majority would do what they had to do, and they took the necessary precautions.
I'll come to your involvement in the outbreak now. Following the conversation you've described with Mr. Aldegur on the 16th of April, did you attend at the home the next day?
I did.
Did you work at Newmarch House between 17th of April and about October that year?
Yes.
In terms of the amount you worked, was it every day, or did you have some days off during that time?
I did have some days off. I did have some days off.
Okay, and in terms of the amount you worked each day, were you working very long days during the outbreak?
I was working incredibly long days, along with a few other people. Everyone was working 12-hour shifts at a minimum. I was working along with some of my colleagues 16, 20 hours, and then we'd be on call after that.
Very well.
Yeah.
So it was pretty much every waking hour. Was that the case?
That's right. Any deaths that happened, I had to ring. We had a bat phone, which I organised in the early days so that we could have communication. That's what we called a bat phone. And we had to make the calls to inform infectious diseases if there was any deaths. So the home would ring us, or ring me on the phone. So it was constant.
In terms of the actual role that you were performing, you tell us in your statement that you became effectively the residential manager of the home. Is that the case?
I supported Melinda. I was asked to go in and support Melinda in the home, which is what I did.
And Melinda, you're referring to Melinda Burns? Yes. Was she in fact the residential manager of the home?
She was the residential manager of the home, and I was mindful that that was her home.
Okay. And did you perceive your role to be supporting her?
That's what I was asked to do, to support her.
Okay. And yeah. Sorry, I had spoken over you. What was?
No, I'd been asked to go and support Melinda and help her manage the home. And so that's what I went in to do at that stage. My role changed a lot, my time there.
How did it change?
I became more clinical. Clinical sort of oversight, I guess. More so, I was doing everything. There wasn't a clear definition of my role, and I really didn't have a clear. I wasn't very clear about what the expectation was either, but I was doing everything with operations, managing stock, rostering, complaints, ordering, infection control, you name it, everything.
In terms of the lack of clarity you've identified there, did you have an idea about to whom you reported? And just focus your mind if you can on the outset of your involvement.
So I reported to Eric Aldiger, he's my boss, however, and he was our regional manager at that time, area manager. But David Goodhue was the area manager of that site, and Gavin Petoris was, again, that manager. So I reported to 3 different people. Eric supported me, I guess, in my role because he was my immediate manager previously. But I was reporting to 3 people.
So the 3 of them. Were any of those 3 on site during that early period?
No.
So when you say reported to, how did you make contact with them?
They made contact with me by phone or by email, or I would ring them by phone or email. There was constant conversations. They did come in when the Baptist team came in on one occasion where we had a teleconference. And we also had some teleconferences. I asked for a couple of meetings as well. So we would meet together by video conference.
Very well. So other than the video conferences and the occasion around Baptist Care, do you recall seeing any of those 3 more senior managers on site?
Not until the 24th, which is, I think, when Baptist came in, which is that Friday, 24th? Have I got that right?
That was your recollection in any event, the same date that the Baptist Care came in. Is that right? Okay. And you pick up on this point, it's paragraph 20 of your statement, but you say this: there was no defined chain of command at Newmarch House when I first arrived. And then you go on to say, but I reported to and took directions from Eric Aldiger, David Goodhue, and regional managers, and Gavin Pretorius, Chief Operating Officer for Residential Care. Just in terms of the chain of command, did you know at that stage who was reporting to you or who you had responsibility for, if anyone?
Well, I guess as a residential manager, all of the staff in the home report to you, but they also reported to Melinda. So there was a little bit of confusion. It was awkward because I didn't want to overstep Melinda, but she was also needing support as well. So there was a care manager. She wasn't there very much. I think she was a close contact and was sent away and then came back and
was that Leanne Hinton?
That's correct.
And given what you've described about the lack of clarity as to who was reporting to whom, did that play out at all in terms of what was actually happening in the home at that point?
The normal hierarchy, I guess, in a residential home was that the care staff report to the RNs report to the care manager, and then the residential manager oversees all of those positions, including catering and cleaning and everything else. So I was in there supporting the residential manager, and I would get handover from registered nurses and be visible on the floor. Yeah, so they knew that I was a manager from Anglicare. We didn't have badges. If we wore them, we would have been covered anyway. So everybody probably looked the same. But I met with staff on a regular basis, but the staff were changing all the time.
And given that, and you referred already to the agency workers who were coming in to work in the home, is this what you're saying, that the way that a home, in your experience, ordinary operated in terms of the chain of command was not happening within Newmarch House at this time?
There was a lot of confusion. I was there when staff came on duty and assisted with the allocation, and so was Melinda. And I guess there was some difficulties there. I didn't know who was who either, because I didn't even know the Newmarch staff. So we were all, there were some challenges.
I want to keep on the theme of the impressions that you had on this first day, let's say, at Newmarch House. Had you actually been to Newmarch House before that 17th of April?
No.
Okay. Well, fixing that point in your mind, if you can, you refer in your statement, this is paragraph 32 if you need to turn it up, but to a number of observations you made on that first day in the process of walking around to familiarise yourself with the site. And one thing is you noted some issues in terms of the PPE.
Yeah. Yes. When I walked in, I saw that everybody was in gowns, gloves, mask, everybody. And there was an expectation that you donned when you came in the front door. That I felt was unusual because it wasn't the normal practice in infection control. At the time, I'd only just walked in, so I didn't want to make any changes at that time. So I went along with donning, putting on gloves, putting on face goggles. So I did what they were doing at that time, but I was confused about it. I walked into the office to say hello to the senior team, and everybody was in gowns and gloves and mask, and I think they had booties on. I just saw this sea of blue and a lot of confusion. I just took that in at that time, and I thought I did ask. I asked Melinda. I said, why is everybody in gowns and gloves in the office? What's going on? That's what she had been instructed to do, she said. So I just let it go at that time. And then I went for a walk around the home. I felt that there was chaos. I wasn't comfortable with the infection control management in the home, mainly because I could see gowns and gloves on floors and in bins and in cardboard boxes, really. There was chairs, lounge chairs being used as tables for PPE. So you can't wash them, you can't clean them, and it wasn't what should have happened. My home, I had tables that you wash down, and I had plenty of them. And so I had all of that prepared, and I knew where to get it from, actually. So we did pilfer from other sites. So when I did that walk around, I thought, this is not what should be happening here. And I bumped into CNC from Nepean Hospital, Robertson.
Was it Robert
Robertson? That day, on that Friday, I remember him being there, and he was with, I can't remember if it was James Branley or Brad Forsyth. I think it was James Branley there.
Just pausing there a moment, if you just flick over the page to page 6 of your statement, you refer to an interaction you had with Dr. Branley and Robert Robinson.
Yep.
And Mr. Robinson is the CNC of Infection Prevention and Control, to your knowledge, is that right?
Yes, at Nepean Hospital.
Okay. And they were on site on this day, the first day you arrived, is that right? They were. And you had a conversation with them.
Yeah.
Remember what the effect of the conversation was?
I spoke to them. I said, look, I'm concerned that everybody in the home and even in the corridors and in the offices, everybody's got PPE on. There's no delineation. I couldn't see any, even between COVID rooms, I couldn't see signage. I couldn't see that there was clear definition as to who had COVID, who didn't have COVID. I was worried that staff were going between rooms. I don't recall seeing signage. I said to them, I'm concerned that we've got these outside areas which now called green areas, green zones. So we shouldn't have PPE in these areas. I mean, we should have masks on, and now we wear goggles. We wouldn't have done that at that stage, but they were in the staff room with PPE on. There was just a swarm of PPE.
Do you recall whether either Dr. Brownlee or Mr. Robinson responded to that? What
they agreed with me, because I didn't want to go into a home make decisions without consulting, because I didn't know COVID. And they agreed. They said, yeah, there shouldn't be PPE in the corridors. We shouldn't be. And so I then made that decision and told Melinda and told Cameron at the time that we shouldn't be wearing PPE in the offices. You must wear your masks, and you've got a hand hygiene, and you've got to do all of that. But there's got to be clinical zones and operation zones or offices. Not even up the corridors. We shouldn't be walking up the corridors with PPE.
As a consequence, did you commence the process of putting into effect those changes?
Yes, I did.
Were they put into effect over what sort of time period? Was it the following days, or?
It was the following day. Made signage up. We communicated to the staff. I closed the staff room. I've met some resistance with closing the staff room, but I closed the staff room because people were looking after COVID positive and COVID negative were all mixing. So I closed the staff room. And we put signage up that there was to be no PPE worn in corridors. And so, yes, there was definite change.
You mentioned signage a couple of times there. What was the purpose of the signage? To show COVID positive and negative areas, or was it related to the residents in some way?
Both, actually. We had COVID positive and negative signs for residents that were COVID positive and COVID negative, so that was put on residents' doors. And we also had donning and doffing signages. They were the ones that we used at Anglicare. We later changed to the Clinical Excellence Commission donning and doffing signages. But so we had all of that, and we later went to toilet zones of COVID positive, COVID negative toilets, and I think that all happened in that first week.
Tell me if this is right.
I was there.
Sorry for talking across you. Tell me if this is right. Was there a process where arrangements such as the one you've described was put in place, and then they were later changed or modified in some way? Was that what happened?
Constantly.
In particular, in relation to the processes for PPE or infection control, is that right?
As far as infection control goes, for hand washing, donning, doffing, that was all. We would follow that process. That was consistent infection control processes. But there were changes in the way in which infection control or the zoning and the cohorting and that sort of thing that changed. It was a very dynamic situation where things would change, and it changed even later after Kathy Dempsey and Clinical Excellence Commission came in, so we made further changes. But and also it changed when Baptist came in. They had more defined order, I suppose, which was really good. they'd experienced it previously, so it taped off areas, which was good.
I want to move on to ask you about staffing matters. I might just commence with this. You mentioned in an earlier answer the lack of clarity, as you saw it, in terms of reporting structures. You also mentioned that you came to assume a more clinical role during your time at Newmarch House.
After Baptist arrived, yes.
Okay, so after the 24th of April, that sort of period of time?
Probably a week after that, actually.
Okay, a week after that. And just thinking, if you fix your mind at that point in time, when you began to assume a more clinical role, what were you actually doing? Were you going in to see residents, or were you supporting staff who were themselves attending on residents?
More supporting staff. I purposely tried to avoid seeing COVID positive residents. The reason for that is that I didn't want to put the management team at risk if I became COVID positive, because that would then take out a management team, and we were constantly being told about close contacts and these people had to go. So I purposely tried to avoid it. However, my clinical experience, also, if I was concerned about a resident that had COVID, or I needed to talk to a family, I needed to have knowledge of that resident. I couldn't talk to them blindly, so I wanted to make sure that I'd seen the resident. So there were residents that had COVID that I clinically assessed and dealt with, but I purposely didn't try to avoid it. So I didn't do the virtual aged care rounds or anything like that because we had someone else do that.
Very well. And in terms of the role you did undertake, did it involve, in part, making contact with the residents' families regarding the residents' care or presentation?
At times, yes.
Given your role as a perhaps more senior member of staff, were staff members bringing clinical concerns to you or issues that they wanted to raise with you?
Yes, we'd get a handover. I would meet with staff and find out if there were any clinical concerns at varying times. So I needed to make sure that things were going smoothly with the residents. So yes, if there were issues, then they'd be escalated. And yeah.
Can I ask about that issue of escalation? So if they came to you and you felt the need to escalate a particular concern, what was your understanding as to who you should escalate it to?
So there was COVID positive residents that came under hospital in the home, and in the early days things changed, but in the early days they would be escalated to either James Branley or Anita Sharma. Anita Sharma would be the go-to person for COVID positive. COVID negative residents, we would contact the GP and get direction from the GP, their personal GP in the home, and we would, liaise with them, but they didn't physically come into the home. So that was communication via phone.
Okay, and you're referring there to the GPs, correct?
Yes.
Okay. Did you see either of the other two people you mentioned, Dr. Branley or Dr. Sharma, in the home?
Yes.
Did you have occasion to escalate concerns to either of them at any point?
Yes.
Okay. And I think you said in your earlier answer that it changed. Did a point come in time, and I've just focused on the COVID positive residents, when your understanding of the escalation process changed?
We continue to work with Anita Sharma with regard to any deterioration in those residents. However, we did have some locum doctors start, not immediately. I think it was 2 weeks after I started there, towards the end of...
Would that be towards the end of April?
Towards the end of April that started, and so on site, and then they took on the role of COVID negative and COVID positive residents as well. They would see them as well. So if there were concerns about those residents, because we didn't have, the GPs couldn't come in and clinically assess people. And so, you know, there were times that bloods needed to be collected, all sorts of things that those locum doctors would see those residents as well.
I want to move on to other members of staff and staffing as an issue generally. Do you have your statement there at which you, so behind tab 5, you've got a number of annexures, and one is an email on page 23 of your statement, which is annexure A, which you actually received prior to the point in time when you commence on the 17th of April. So this is an email dated the 16th of April. If you're able to turn it up, please do so. Do you recall getting this email?
I do.
In addition to wishing well and noting that, sorry, this is from, is it Uditha Abiyaratne? Yes. She was somebody known to you, was she?
She was one of my registered nurses from the home previously. She was working as an educator. She wasn't on my staff at Donald Coburn at that stage, but she had been one of my registered nurses at Donald Coburn. So I'd worked closely with Uditha.
Given that context, and just have a look at it. So in the second sort of paragraph of the email, Uditha's noting, I've worked there looking after COVID, she's referring here to Newmarch House, worked there looking after COVID positive residents for the last 3 days. It is me and Leslie on alternating morning shifts working as RNs looking after infected residents. She says the number of residents with positive swabs are increasing every day and they were in different sections. We still have only one RN and one care staff to look after all those residents. Now this is her speaking and not you. Fixing your mind on the next day when you arrive, what was your understanding of the staff that were present there to look after the positive residents?
My understanding is that the surge workforce were escalated and they were sent in to look after the COVID positive residents. A lot of the Newmarch staff had been sent home because they were contacts or they were infected with COVID, or so they send in the surge workforce to look after COVID positive residents. And I did catch up with Uditha and Leslie within the first day or 2 days of me being there, and they were stressed. They were exhausted.
On that first day, did you understand the situation to be as Uditha is describing it? That is, one nurse and one care worker to look after those residents who were then identified as COVID positive?
Yes.
Sorry to jump around, but if you have a look at paragraph 46 of your statement, back on page 8 of your statement, this is then moving to the next day, which is the 18th of April. You say at 45, I arrived at Newmarch House at about 8 a.m, and then you say this in 46. It was immediately obvious when I commenced my shift that staffing was an issue. The residents' buzzers were going off, there were delays in breakfast, and residents were complaining they had not been fed. You also mentioned there that a diabetic resident who was negative, a COVID negative resident, has not received his normal insulin and had a high blood sugar level. Just fixing your mind, if you can, on day 2 here, do you recall there being a particular issue with staffing, and if so, what was it?
I recall day 2, day 3, day 4, right up until the Tuesday, that we had staffing shortages. Staffing was acutely an acute issue. The fact that the resident hadn't received his normal insulin that alarmed me a lot. I had to try and stabilise that resident and organise everything with that registered nurse who was clearly inexperienced. And so I was on the floor trying to assist with clinical care. That was up in Flaxland Wing, that I became aware that buzzers were going off. I was doing a round to see what was going on. So yes, clearly there was staff shortages, and inexperience.
Do we understand from that paragraph that what was happening was that residents were seeking care and not being responded to, or seeking some assistance not being responded to? Is that what we understand?
Yes.
And is it your view that in consequence of the staff shortage that care was not provided as you would hope it would be?
Yes.
I just want to move on a couple of days later to the 20th of April. This is at 63, which if you move forward to page 11, you develop a similar theme. You say this: on 20th of April 2020, Newmarch House was extremely understaffed. You say this: many of the staff had been, many of the staff that had been rostered to work had been contacted by the New South Wales Public Health Unit and advised that there were close contacts and told not to attend work. New South Wales Public Health Unit did not inform us that the staff had been directed not to come to work. Staff members had assumed that the New South Wales Public Health Unit had told us about this, so did not contact us either. This failure in communication led to significant shortages in staffing. Do you recall that day?
I do recall that day. That was the worst day of the outbreak.
What was the consequence of the failure in communication that you've described? What actually happened on the ground on the 20th?
None of the catering staff came in. That was the first thing. So there was somebody from catering that tested positive, so they were told not to come in. So it took out the entire catering team. Registered nurses didn't come in. I don't recall whether they were because they were COVID positive. I know that the whole catering team had been told not to come to work, and that caused significant problems. There were care staff that had been told they were positive, or that they were a close contact. So that day in particular was a very, very bad day. And I remember Dr. Branley being upset that day as well when I'd spoken to him, because of the fact that things were not going as planned.
Things not going as planned. If you have a look over the page at 66 in your statement, you've referred here at 65 to also being short of nursing staff. So it wasn't simply the catering staff that you mentioned, but it was the nursing staff as well. Is that right?
That's correct. One of the registered nurses, I think she was the one that was meant to have given the insulin, said to me she hadn't worked as a registered nurse before. She was registered, but she'd never worked as a registered nurse before. So we had agency staff that had absolutely no experience with as a registered nurse, let alone working in a COVID outbreak with infection control requirements. So we had, it really was a crisis situation, and that's when I asked Leanne to go on the floor and work as a registered nurse to make sure that we were at least getting insulin and medications administered in a timely fashion. And then I also got, we just mobilised our entire team to get breakfast sorted, escalated it to Eric, and they organised for a team to come out from, I think it was Donington, one of our other homes, brought out that catering manager and we mobilised. The residents got fed, they were late, and there was a lot of media publicity around that time as well about late breakfast. So I had Monica, sorry.
Was it Monica Tucker?
Tucker.
Was she a nurse?
She was a CNC. That was her first day as well. So we all went on the floor. I had cleaners doing breakfast to try and feed the residents because we were stuck. So we got it done. We got everything done. Admittedly, they had breakfast at 11 o'clock in the morning or something, but we got there. We all worked really hard.
I don't want to upset you with this question, but just putting your mind back on the 20th of April 2020 and thinking what it was like to work through that process, what effect did it have on you?
That was probably the worst day of my career. There were others that happened after that for different reasons, but I feel that I have a very high standard in what I require for patient care, and every one of those residents is like my mum and dad. So, you know, I can't imagine being in a situation where we just didn't have the staff. We just didn't have the staff to be able to do what we needed to do. I was in there toileting residents, which I don't have a problem with, but I was in there toileting residents and supporting them. So I think most of the residents, to be honest, were so good. They probably didn't experience the distress that we felt, to be honest, in our immediate inability to deliver good clinical care at that stage. At that stage, we did improve, fortunately. Otherwise, I wouldn't have been there any longer.
Fixing your mind to that point in time, on the 20th of April, you referred there to making contact with Mr. Aldegar in order to source staff from another site, correct?
I did. I spoke to James Branley because I said, we really don't have staff. This is what's going on here. We haven't got the resources. We can't provide care if we haven't got staff. And he advised me to contact Nepean Hospital and speak to the Director of Nursing, because at that time Nepean Hospital wasn't busy. And sorry?
When you've described to him the difficulty you've expressed just there about the staff, but do you remember what his response was?
He was aware. He was frustrated on that day. He tried to do a round with Leanne, and he was equally frustrated.
Did he say something to the effect, and this is paragraph 66 of your statement, that things at Newmarch House were deteriorating?
Yes.
What did you understand him to be referring to?
He expressed his frustration that that he'd seen residents that he were concerned about, that that weren't getting, I guess, the care that they needed, and it was mainly because of the fact that we didn't have the staff at the time. I think he got frustrated with the round that he did, and then I put Leanne on the floor at that time. So he told me to ring Nepean Hospital and try and get staff, and I did. I spoke to the Deputy Director of Nursing, and she gave me a contact for the operations manager, and I then forwarded that to Eric and said, or to Sharon, I think, Cumming, who was doing rostering, and said, they also referred me to Nepean Private and said, see if they can provide staff, because they're not doing any surgery, so they might have staff. We didn't get any from them.
Did that source of staff ever materialise?
No.
Staying on this topic of staffing, you mentioned, as I say, having made contact with Mr. Aldiger, but just fixing your mind on the 20th of April, did you feel personally that you were getting the support from your senior management within Anglicare that you felt you needed?
No.
And what do you mean by that?
I guess what I could see was happening on the floor was different. They had different priorities. They had priorities because they obviously they were getting complaints constantly. They were looking at communication, family contact. I was looking at clinical care. I had trouble communicating, like, I guess explaining that. They did action because they got the team out from catering from Donington to come out, and so they did action it, and they did understand that I had a real concern about staffing levels. So definitely did. But I guess it's different when you're on the floor in the bubble that we used to talk about than being outside and understanding. You don't get the right feeling when you're external. You can communicate it, you can tell people, but unless you're there, seeing buzzers go off and seeing stressed staff and having no food as well for staff, difficult.
You've already told us that there were occasions later on when staff, more senior staff, did attend the home. During this period, as at the 20th of April, had you seen any of the senior management, that is your superiors, at the site at all?
No.
I'm going to come back because you mentioned some concerns about clinical care. I'll come back to that topic in a moment. I want to move to a separate topic, which is hospital in the home. Did you understand prior to your commencement in Newmarch House what hospital in the home was and how it operated?
I'd worked as a CNC for aged care previously, so I had a bit of an understanding of what that would mean. We tried previously to keep residents in residential care where possible instead of sending them to hospital because of the potential for complications. So I understood that concept of trying to maintain them in the home.
Very well. So given that prior knowledge you've just expressed, when you came to start at Newmarch House, did you come to be aware that there was, well, what model of care did you understand was operating at Newmarch House at the commencement of your engagement?
I understood that hospital in the home was in place. I spoke to, I think it was Hayley Carpin that first day that I was there, and understood that that was the model of care. I didn't have anything in writing with regard to that at that stage, and I'd worked with Hayley previously, so it was, and I'd worked with Dr. Anita Sharma previously as well, so I was able to communicate with them quite well, I suppose. So I asked for some hard information about what the process was. So that's when I got sent the flowchart.
Okay. Taking you to your statement, do you recall during that conversation that you had with Dr. Brownlee, this is on the 18th of April, and you refer to this at paragraph 50 and onwards in your statement. Do you recall there being a discussion at that point about the VACS and the hospital in the home programs? If you just direct your attention to paragraph 53.
Yeah, look, I guess I wasn't overly clear on the process. I knew that we had hospital in the home, that the residents would come under, because it was only COVID positive residents would come under, then they'd come under infectious diseases. That was the model. That was the, I guess that's how they were admitted on paper through the hospital. That's how they would come in, but they then clinically would be overseen by geriatric team, and that was the virtual aged care service. So that from a clinical perspective, that's who would oversee them, which is typical in aged care for these residents to come under geriatric medicine.
Was the virtual aged care service a service you had previously had contact with?
In my previous...
Yes, your previous role. No? No. Just want to focus your mind on this, and you deal with it in paragraph 53 of your statement. But did you have any discussion with Dr. Sharma on the topic of the process for transferring residents to hospital?
I know that if there were any residents that required hospital transfer, that had to go through Dr. Sharma, and that's in that flow chart. So that I didn't realise that straight away, because I'd transferred somebody when I first arrived there to hospital without that process. But I became aware that any residents that need to go to hospital, you'd get approval before they could go to hospital.
Very well. And when you referred a couple of times there to the flow chart, just have a look at Annexure G, which is page 43 of your statement. This is an email sent to you. It's forwarding an email sent to you on the 20th of April.
Yes.
It's from, I think it's Professor Sud, S-U-D, referring to a previous conversation that you'd had.
Mm-hmm.
And attached to that email is a flow chart, so it commences on page 45.
Yes.
And onwards. Is that the one you're referring to in your evidence? Yes. Okay.
So they sent this through to me because I wanted something concrete to be able to refer to as to how it was going to work in the home.
Very well. And in terms of the point that you just made about the process for transferring to hospital,
mm-hmm.
Did this flowchart inform you about that at all? Did it confirm?
Yes, it does.
Okay.
Yes, it does.
Did you understand the situation to be that if you were considering or wanted a resident to be transferred to hospital,
yep.
you needed to contact VACS in relation to that?
That's correct.
Okay. How did that play out in practice? Were there, did you encounter a situation where you felt a resident was deserving of consideration to be transferred to hospital?
On a couple of occasions, we had one resident in particular. Do I say their name?
Can you give their initials first of all, just in case there's an issue?
J, I think. Who?
Okay. Was it just one resident?
No, there were a couple.
Okay.
But that one in particular, she had a fall.
Okay.
Fractured her ankle.
Okay. And she was a resident. Do you know that she was a resident who survived?
She survived COVID.
Yes, I see. And in relation to her, just talk through the process. What, having formed a view, is this right, that you felt it was appropriate for her to go to hospital?
It was definitely appropriate for her to go to hospital. She needed to be in hospital.
Okay.
at the time we had an Aspen, a very capable Aspen clinical nurse who was overseeing that wing. And she spoke to me about that resident and said she's got to go to hospital. She's in pain and she needs to go to hospital. There was a delay in the hospital transfer, and I understand, you know, that there's requirements for consultation with other practitioners, I guess, in that process, but she definitely needed hospital admission and needed transfer.
In terms of the tell me this, was it different in any way in your experience as a residential manager at a different care home, the process of transferring a resident to hospital?
Yes.
And so how did it differ?
If we had somebody that we felt needed hospital transfer, we'd clinically assess them, we'd make a decision, we'd contact the family. Depending on the advanced care plan and discussion with the family and what was actually happening with that person, we'd organise ambulance and transfer them. We didn't have to consult with anybody. In fact, didn't even ring the GP on a lot of occasions.
And when you're saying we, is that the residential manager that makes that decision or somebody different?
Registered nurse is in charge, or registered nurse that's looking after that patient. There might be consultation with the care manager.
Okay. And you mentioned in the case of that particular patient you've identified as J, was that, you mentioned delay. What was the source of that delay?
It was the decision making, I think, in coordinating that and getting the ambulance out and getting approval for her to go. I think, I mean, it had to be coordinated with emergency department, and so there were delays. I know that the Aspen RN was very frustrated at the time and expressed that frustration about the delay in getting her to hospital.
Just while we're on issues of clinical care, there's one other matter I want to just ask you about, which is paragraph 54, just over the page on your statement. And to put this in context, this is the evening of the 18th of April. You say this: at around 7 p.m. that night, Pharmacy for Less delivered several large boxes of medications to the home, including 18 packs of morphine, which is a Schedule 8 drug, as well as midazolam and Robinol, which are both Schedule 4 drugs. Just was that remarkable from your perspective? And if so, why?
I guess we don't normally order crisis medication or that medication until we've got somebody who's dying. So the fact that I had all of this medication arrived, I thought, at the time, oh my God, there's an expectation that every one of these residents is going to need this medication. And that hit me for a sixer, to be honest, at the time. Yeah. But I'd also heard it on the media about people dying left, right and centre overseas. So I guess it just hit me hard at that time.
At that time, on the evening of the 18th of April, did you at that time have an understanding as to how the crisis medications had been ordered and how they came to be at Newmarch House?
I was told that they'd been ordered by the VAX team. They were ordered by the VAX team. They just all arrived because I didn't really get told that they were all arriving. They arrived at 8 o'clock or something that night, 9 o'clock that night, and then I had to try and lock them all up.
Is that a process you need to go through with those particular medications?
Yes.
Do they have to be kept securely, in other words?
Yes, they do.
And in terms of the moment of shock, my word, but the moment you just described in your evidence, on seeing these medications, did you form the view that there appeared to be an end-of-life situation for one or more residents in the home?
18.
And although they'd been delivered to the home, was it your understanding that in fact they'd been prescribed at that point in time?
Mm-hmm. They have to be prescribed to be able to be dispensed from pharmacy.
Yes.
I think that I do recall being informed that there was concern that if a resident deteriorated over the weekend, that we needed to have the medication available. And that's why it was sent.
And finally, on this topic of medical matters you've referred to in your statement, just on paragraph 59 on the same page, and this is going over to the 19th of April.
59, sorry.
So you're on page 10 of your statement.
Yes. So page 10, yep.
Yeah, and just put this in context, you've said that on the, you referred on the 19th of April to, among other things, Bunnings Warehouse delivering tables and bins. That's with reference to some steps you took to set up PPE stations and disposal of PPE, is that right?
I did. That morning I went to Bunnings and bought every table that they had and bins so that we could try and have the infection control sorted. I rang Cameron, asked him to go to a different Bunnings. So we bought everything that I could fit in my car and what they had, and I asked Shihan to order it. So we then ended up getting in all the tables and the bins, and every resident actually had a table outside their room with PPE on it because everybody was being nursed. Infection control precautions were in place.
Very well. And that was that in, tell me if this is right, was that in response to what you'd observed on your first day and the evidence you've already given about that?
Yes.
Okay. And if you look down at 59, one of the things you note on that day is that you needed more monitoring equipment, including thermometers, oxygen saturation equipment.
Mm-hmm.
Just in that context, did you notice a shortage, or what was the context for that realisation?
It was a bit of everything. We didn't have enough equipment because we're taking temperatures on people coming into the home, like staff. We didn't have enough equipment, and the equipment that we had wasn't medical equipment. That was the other concern. It was what you buy at the chemist. So that's why I said we need proper medical equipment, because the saturation monitoring and the thermometers were not appropriate for a medical environment. Some were, but we didn't have that enough at that time. And I do understand that as well, though, because I tried to buy it from my home before going to Newmarch, and there was a shortage of getting thermometers and saturation monitors and things like that. There was a shortage in New South Wales.
And this was 19th of April, so would that be about day 8 into day 9 of the outbreak in Newmarch House, to your understanding?
Yes. Some of the equipment would work, some of it wouldn't. And that's why I said we need the right gear.
Did you make a request to your superiors for that equipment?
Yes.
Did you make it on that day, on the 19th?
I made it as soon as I became aware that we had a shortage.
Okay. And just over the page, do you recall in particular, there were some blood pressure monitors that you proposed should be obtained.
Yes.
Expensive pieces of equipment.
What we use in intensive care, and I felt that this was a high dependency unit.
Okay, and they were requested. Do you recall when they were delivered?
And they were delivered.
Do you recall when?
I just have to go by my statement. I can't remember, but...
So 24th of April on page 11, does that sound right?
That would be right.
Okay. You've expressed some views on the operation of hospital in the home as you observed it. And if you have a look in your statement at paragraphs 89 and onwards, you talk about this topic. I just want to ask about a general view you've expressed, and that's in 92 of your statement. You say this: in my view, HIF, that's hospital in the home, generally works well, but there were limitations in its operation at Newmarch House, especially in the context of a COVID-19 outbreak. For instance, Newmarch House did not have radiology or pathology on site, which is required when you are treating such a large number of critically ill residents who require immediate imaging and pathology results. There were occasions when I was asked for a resuscitation trolley or an electrocardiogram machine, and it was frustrating for doctors when I informed them that Newmarch House was an aged care facility and did not have such equipment available. Just pausing there, is that an actual interaction you're describing, that you were asked for that equipment? Yes. Who was it, you remember? What a role of that person, if not the name?
It was the doctor, it was the locum doctor.
And was this in that period after they commenced at the end of April 2020? Was it the people who were physically within the house?
Yes.
Okay. And in that context, what was the request that was made?
We'd been asked for a resuscitation machine, resuscitation trolley, because we had a resident that had had a hypoglycemic event, and I'd been asked for that, and I said, we don't have resuscitation trolleys for an aged care home.
You go on the next paragraph to note that it was difficult to facilitate intravenous treatment. Just thinking of that for a moment. In your prior experience, so appreciate it wasn't Newmarch House, but in your prior experience, was intravenous treatment something that was undertaken within the aged care home? No. Had it ever, to your recollection, been undertaken in an aged care home?
Yes, only to give IV medications such as antibiotics. And they would be then under community nurse, or somebody would come out from the hospital. We didn't have the staffing levels to do IV therapy. Previously, like in a general residential aged care facility, you don't do that. You would, we may do subcut fluids, but that was not often either.
And moving to the period of the outbreak, what's your recollection? Were there occasions when intravenous fluids or medication were required? When you say you've said it's difficult in your statements, so I'm just trying to understand, was it in fact done, or was it not?
It was. Okay. There were two residents that were on a medication that they needed. They had an infusion that they required, I think, every month. I can't remember what the infusion was, but they required this infusion. They would normally go to hospital for that infusion.
And what happened in their case?
In their case, because they still required the infusion, Hayley Carpin came out and would do that infusion. I can't remember what the drug was.
And is that the only occasion you can call to mind when something was given intravenously to a resident?
There was another occasion which I understand. I was asked for IV therapy equipment. That was for one of the residents that was COVID positive. And Hayley brought that equipment in as well.
You talk in 94 of your statement about Dr. Sharma wanting to perform a blood transfusion on a resident.
Yeah.
Can you recall that event?
I do recall that.
It's not a resident we need to name, okay, for the purpose of this
I don't
question.
recall the resident.
Very well. But in those circumstances, what was asked of you or your staff that day? Do you recall?
I was informed that somebody had a very low hemoglobin and they would have to do a blood transfusion. I was very concerned about that in the home because blood transfusions, in my experience, are also, there's a high risk of anaphylaxis. There's also, there's risks for the resident, and I didn't feel that the home was the appropriate environment for that infusion.
As a consequence, what happened?
I don't recall. I know it didn't get given in the home, but I don't recall. I can't recall the resident, and I can't recall. I don't believe. I can't recall.
Okay. You've also you turn it up if you need to. It's 118 of your statement on page 21. You've expressed another sentiment in relation to this topic. You say this: I believe the most challenging aspect of the decision to care for the residents at Newmarch House instead of at a hospital was that there was an initial lack of staff, and many of the staff were not adequately trained or experienced in acute care settings or even aged care settings. In my view, you continue, the environment of COVID-19 positive residents in Newmarch House was identical to a high dependency unit in a hospital, as there were residents who were rapidly deteriorating. Just in that context, what are you expressing there in terms of Newmarch House being identical to a high dependency unit?
The residents would deteriorate fairly rapidly, require oxygen, require monitoring, require observations, require good clinical assessments, and the staff weren't trained. I had staff that were from the eye hospital. I had staff that were from, various areas that were not, they didn't have the experience. So that was difficult. Having said that, though, we did have some staff come in that were experienced, and some of the Aspen staff were good. The St Vincent staff were good. So we did get staff in, but the most difficult thing was that we didn't have staffing levels that we required to provide the care. And I think hospital and the homes are a really good model of care for managing cellulitis, managing urinary infections, things like that. I hadn't experienced it with a COVID outbreak. Nobody had. And it may have been okay because there wasn't a great deal that you could do for those residents, but we didn't have the staff. It was mainly, it's a good model of care, but we needed to be able to support that model of care.
And you said we didn't have the staff. Was it in addition to the numbers, as you said in your statement, that the adequacy of the training and experience of the staff who were actually present that was a difficulty? Mm-hmm. And just to give that some content in terms of how it played out, did you observe in your time any difficulties with the staff actually undertaking care or medical reviews or steps in relation to the residents?
I object to that question. It has about 3 or 4 elements that relate.
I'll break it up. I'll withdraw it. Can you bring to mind an instance where you think either a lack of available staff or a lack of training in staff caused a difficulty?
Well, I think it should be identified what sort of difficulty is my learned friend talking about.
One moment. Withdraw the question. You've said in 118 you believe the most challenging aspect of the decision to care for the residents at the hospital was the initial lack of staff, and that many of the staff are not adequately trained or experienced. Let me take you to one aspect of care, okay? Observations, okay, of residents. Was that part of the ordinary routine duties of staff within the home? Yeah. Taking that by way of example, did either an initial lack of staff or the fact that staff, in your view, were not adequately trained and experienced have an impact on that aspect of care?
I don't think so. Not day-to-day observations and care. I don't think so, no. It was more when there was more complex issues, such as diabetes, insulin management.
And what is it in those complex issues that resulted in an issue from your perspective?
Newmarch House had a lot of diabetics in that home, a lot more than most homes that I've worked in. And I guess part of my role, I also educated staff. So I was also educating on the floor in managing diabetes and managing that side of things. So I did find gaps in some of the staff's knowledge with regard to diabetes.
Very well. And if I were to suggest there's probably about half a dozen of the residents who had diabetes, does that sound about right, or was it more than that?
More than that.
And in terms of the sort of steps that need to be taken in respect to such a person's care, what was your concern about the staff who didn't have adequate training or experience?
Knowledge of administering insulin, knowledge of actioning changes in blood sugar level, and of knowing what to do if somebody had a hypoglycemic event.
In terms of the knowledge on what to do, another aspect of care I'll ask you about is, in light of your evidence about taking observations, is a deteriorating patient, so a patient who is showing signs of deterioration. Can you bring to mind an example or any concern you had about the staff you've identified in that sort of situation?
No, not specifically, but I do recall having to go and clinically assess residents myself when I saw that saturations were low, and that not being escalated. So I'd go and clinically evaluate those residents. So I guess in prior to COVID, care staff didn't really do observations or oxygen saturation, so they don't understand what it means, what normal parameters are. Prior to COVID, we've all learnt a lot since then. So, you know, things like that. If I noticed that there was a change in observations or that there was a problem, I'd go and follow that up, or I'd get the registered nurses to follow it up. I guess that's the areas. So we had staff from varying backgrounds, and I honestly didn't know what what their knowledge was. So or experience was.
Thank you. In terms of, sorry, withdraw that. A related topic, or a separate topic, sorry. If I move to this, 105 of your statement, you refer to a general topic under the heading difficulties with COVID-19 testing. There's something focusing your mind in the first few weeks of the outbreak. You're here noting in the first sentence of 105, the results of the COVID-19 testing of staff and residents were not made available in a timely manner. Just doing the best with your recollections on that, what was the difficulty that was occurring?
I know they did COVID testing before I got to Newmarch. There was a delay in results coming through. We didn't necessarily get a lot of the communication about results was by phone. We didn't get hard copies. We weren't informed if someone was negative. We were just informed if they were positive. And there were delays. So swabs were taken and then the results came later. It didn't necessarily mean that we had escalating COVID cases. It was the results were delayed. So although, just as an example, say the swab was done on a Tuesday, we may not get the result until the Saturday of a positive case. So there was delays in results coming through, and then the media would find out, oh, there's another case, there's another case, there's another case. So it looked like there was an escalation of COVID in the home, wherein in actual fact, there may not have been, if those results had all come through at once. It wasn't a escalation, it was more delays in results. And to be honest, we didn't have any more cases after 3 weeks. And I think if a lot of the cases that we had initially were probably initial exposure, but the results were dribbling through. And we were getting called, I was getting called by PHU at 10, 11 o'clock at night, saying somebody's positive, this person's positive, who's the close contact for that person, who have they been working with. There was just, yeah, that was, and I guess that they were under the pump. Public health were under the pump. Everybody was.
You refer, paragraph 51 of your statement, to communication with the public health unit subsequently occurring by something called the backed phone.
Yes.
Do you recall that?
I do. I put that in place after a meeting I had, probably, I think it was the Saturday or Sunday. I asked for a meeting. I was concerned because communication was poor in the home, and I'd had complaints from public health about trying to get through to the home and trying to give results, and they couldn't get through. And so I asked for a dedicated line, so that I got a dedicated mobile phone. That was very early that week. I can't remember whether it was a Sunday or the Monday.
Is that the week that you started?
Yeah.
Okay. As a consequence of that phone, did the communication issue you've just described improve or not?
It did improve from, it was a high-end phone call. So it was a high-end, it was for senior staff. It was for James Branley to contact us, Bradley Forceman to contact us. It was for, senior people. It wasn't given out to the public. It wasn't given out to staff as far as calling us for any particular reason. So it was that communication which was really important that we had to know, had to find out about for positive residents that we had to manage. So that communication improved from that perspective.
Also, the type of communication you've mentioned also in your statement, the communication with families, this is 112 and onwards, was that a major problem?
Yes.
In your perspective during the outbreak?
Yes.
And what was it? What was problematic about the communication with families?
The phones were diverted from Newmarch off-site to head office. There's reasons for that because we had numerous phone calls. There was, every resident had a relative, but a lot of residents have a lot of relatives. And so the phone calls were constantly coming into the home, and we were either there, we either had to prioritise care or we had to prioritise phone calls. And I know myself, I had occasions where I had so many messages on my phone. I either spent all day doing messages and emails, or I stayed with residents, and my priority was the residents. And I recall a registered nurse upset because I said that we needed to ring the families. We needed to ring the families. Please make sure that you're calling the families and contacting them. And she said, I have a resident on the floor. I've got a family member ringing me. What do I do? I said, you've got to look after the resident on the floor. She said, well, I did. So there were complaints about that.
Did you become aware generally of a problem people were expressing in being able to contact Newmarch House?
Yep, doctors.
Resident families as well?
Resident families.
On the resident family side, did the point come in time when improvements were made in that communication?
Yes, absolutely.
Do you recall how it came about?
I think the number of complaints that were coming into the home and the media coverage about that lack of communication, and rightly so. That's where it came about. And we then had a team of people that came in and assisted with that communication, which was awesome.
And was it in fact registered nurses who were assisting
Yes.
with those calls to families?
Yes.
To your knowledge? And reflecting back over your experience in terms of how that communication was impacting on your other responsibilities as you've described, and what later came to pass in terms of the dedicated team, but what's your view about whether that may have been an advantage to have throughout the outbreak?
That would have been a significant advantage right from day one, to have a communication team, because the staff were extremely busy looking after care and residents, while managing also all the PPE requirements that took immense time.
You've expressed in your evidence already the fact that you've said initially there was a lack of staff, full stop. There came a time, did there, where the staffing levels improved? Mm-hmm. Is that right? Mm-hmm. Just focusing on that period when you felt there was a lack of staffing, I just want to ask you about some evidence we've had from a different witness in this case. Do you recall Dr. Kakat?
Yes.
A member of the VAX team, is that how you understood him to be? Yes. He gave his honour some evidence to the following effect, that he, in terms of, this is on the topic of the way in which care staff were making observations of residents. He says to his honour that he saw staff walking along the corridors and checking in with the patients every 30 to 60 minutes by opening the door to observe them and observing them from the door. Just want to ask you, do you have a recollection of that sort of regularity of observations happening of the residents?
It depends on the time period of time. The initially that wouldn't have really been possible. Probably when we had optimal staffing, it wouldn't have been a problem. And I tried to get staff to make sure that when they went in and saw a resident, they did everything for that resident while they were in that room. They were checking residents regularly. I do know that. They were checking residents regularly. I think that initial period, like the serious staffing issues that I experienced were between the 17th and the 21st of April. After that, staffing improved. I actually sent through what I felt were the required staffing levels to my boss to try and improve the situation. And the staffing levels did improve.
I don't need to take you to the detail of it, but you've included within your own statement that particular email that you sent to your superiors. Do you recall?
Yes.
And in fact, you set out within that email numbers in terms of numbers of nurses or care staff that you felt would have been necessary. Correct?
Correct.
Okay.
At that time, based on the numbers that we had positive at that time.
Thank you. And when you say at that time, if you need to turn it up, it's annexure F, which is page 32 of your statement. But it's an email you sent on the 24th of April, commencing, I've had a clearer head today, please find attached duties list for the registered nurses and carers. And you go on to say, it's what you believe are the required care, RN and lifestyle staffing levels if we are to get ahead on this outbreak and minimise the concerns.
That's correct. I ended up taking a day off on the Wednesday.
You say in your statements is 73, so it's the 22nd of April you took a day off. Does that sound right?
That would be right. And I went away and threw a whole lot of stuff together, knowing what was going on and what we needed to do from staffing perspective, so that, and that was the minimum staffing that we required, I felt at that time, so that we could manage infection control and manage resident care effectively.
Very well. And did around this time, just to fix these dates in your mind, do you recall that staff from Baptist Care commenced on or about the 24th of April?
Yes, I do.
Around the same date, and possibly from the 25th of April, nurses attended from St Vincent's?
Yes, I know that, yes, they came out from St Vincent's.
And were there also care staff, to your knowledge, being provided either by Aspen Medical or by Mabel?
Yes.
The difficulties you've expressed in terms of staffing numbers, did they improve from that point forward?
Absolutely.
Yeah. I mean, perhaps if I approach it this way, the numbers you identified in your email, in terms of the minimum numbers of nurses and carers, were they subsequently met? That is, you've identified, it's page 34 of your statement. Do you have that table in front of you?
I do.
So it appears to be broken up into two 12-hour shifts, the top of the page and the bottom of the page.
Yeah, morning shift and afternoon shift.
Okay, and are you expressing here the numbers of nurses and carers in total that you think need to be supplied?
That's correct. I told them how many registered nurses we need, I felt, in each wing, and how many, and then a total of the staffing and how many carers we would need to provide care at that time as well.
Okay, so working through the number of a nurse for COVID positive residents, a nurse for carer documentation in Blacksland, and 2 at each of those at Lawson. That takes us to 6 nurses on the AM shift. So where it says COVID RN total in the grey column.
Yes, that's correct. So, yeah, 3, 4, 5, 6, 7. 7 registered nurses. Actually, if you go down further, total RNs and med carers, so there's 5,
yes,
7, 13 in total registered nurses I felt that we needed at that time.
Okay, so...
And that was minimum.
So having spent the time on your day off working out what you needed and having sent this email on the 24th of April, I took you to some of the staff that were then introduced into the home. But can you answer this question? If you can't, say so. But were your expectations or your, such as they were set out in this document, were they actually met? Did you get that level of staff?
Yes, we did. We did. The staffing levels increased. We had Aspen staffing come in. We had the St Vincent staffing come in. We had, yeah, we definitely had an increase in staffing. And was it in response to what I had asked? I can't tell you, but I verbalised concerns with regard to staffing.
This may be stating the obvious, but given that email was sent that day, you say those staff were then made available. Was the situation very different prior to this email?
The situation was very different up until the Tuesday, which is, the Monday, the 20th, is when I really created. And then the next day, so I was reassured by my manager that staffing levels would improve, would increase, and they did increase. So it was really probably from the 21st that staffing levels improved, which was prior to this, but I took the next day off and wrote it out so that we couldn't have any further confusion about what we required to manage the home.
Thank you. I just want to finally turn to this topic, which is you've already written at the end of your statement about some of the reflections that you have over the time. But I just want to ask you if there's other things that you feel you'd like to say to His Honour in terms of your reflections about the outbreak and what you dealt with in your position during that outbreak.
This outbreak was probably the most difficult time for myself, more so the staff. It was an exceptionally hard time in that first period, but I honestly feel that despite what happened, we were able to contain that outbreak within the first few weeks of that starting. We didn't have any further positive cases from my memory for residents after about the 25th of April, and to contain even a influenza outbreak in that period of time is difficult as it anyway. But to contain a COVID outbreak within that period of time and not have any further escalation in the numbers, I thought, when we think about that, I think that we contained it well. And I'm terribly, terribly sorry for the families and the residents that we lost during that time. That was terrible. But I strongly believe that everybody worked so hard, and so did Anita Sharma, and so did James Brantley. Without them, we wouldn't have been able to do what we did. They worked so hard, everybody did at that time. And we did everything in our power to provide the best possible care that we could within the resources that we had at the time. And I got the resources that I needed from Anglicare whenever I asked for them. So they were supplying our resources that we needed. I don't know, I guess that's my reflections. I think that overall we contained COVID in the home. And so much has changed since then. I've been to multiple outbreaks since then, and they haven't been, fortunately, to this level. So I think there's been a lot of learnings in everything. Anglicare's learnt a lot. Public health, I'm sure, has learnt a lot. I'm sure Nepean's learnt a lot. Everybody's learnt a lot from this, and there's been so many changes to COVID management now, everywhere.
Ms Giles, thank you. Those are the questions from me. Thank you.
Thank you. Ms Giles, I'll just check whether there are any other questions for you from the other lawyers. Ms Clark, do you have any questions for Ms Giles?
No, no questions, Your Honour.
Thank you. Mr Palfrey, any questions?
Thank you, Your Honour.
Ms Van Ness, do you have any questions for Ms Giles? No, thank you. Mr Fordham, do you have any questions?
No, thank you.
And Ms Richardson, any questions?
Just one question, please. Ms Giles, you gave evidence in relation to a flow chart that you referred to in your witness statement that was provided to you. Perhaps, do you have a copy of your witness statement there?
Yes.
There are various numbers on there, but there's a number on the bottom right-hand side, page 45. Do you see that?
Yes.
What did you display that or put that anywhere in the facility when you received it?
When I received this, I printed it off. I put it in each of the RN offices. I put it in the head office or in our office, and I emailed it out from memory to the management team. So it was put on display along with contact details.
So I've referred to page 45, but if you wouldn't mind looking at pages 46 and 47.
Yep.
So does the evidence you just gave apply to those pages as well?
Yes,
or just
that's
the first,
correct.
all of those pages?
Yes.
Those are my
I
questions.
believe it was laminated and put up.
Thank you.
Thank you. Anything arising, Mr Harris?
There's nothing, thank you.
Thank you. Ms Giles, that brings us to the end of your evidence. Thank you very much for attending today. You're welcome to leave a seat there. Thank you.
Your Honour, that's what this is for today. I think for tomorrow we have scheduled Ms Wunsch and Mr Millard.
All right, very well. I'll adjourn until 10 o'clock tomorrow morning then.